Good afternoon, everyone, at least everyone who's on the East Coast. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, and I'd like to welcome you to today's virtual symposium on school-located vaccination strategies to increase child and adolescent immunization rates during the COVID-19 pandemic. We're very pleased to bring together an outstanding group of leaders in education and public health, people who are on the front line, researchers who are involved in these issues, public and private officials. We hope that this can be a critical and timely discussion on how to protect children and adolescents from COVID-19 and vaccine preventable diseases and consequences as they return to in-person learning this fall. It's been a challenging and unusual back to school season this year, to say the least. And I know many of you all have been working around the clock to ensure that students can learn and grow in safe, in-person learning environments. We want to thank you for that hard work and also provide a moment to reflect on what we've learned during the last months of COVID-19 vaccine distribution and where we need to go to ensure that all children and adolescents are well protected from all vaccine preventable diseases. We're making progress in vaccinating our young people against COVID-19, with just over half now of all adolescents aged 12 to 17 fully vaccinated. But we're going to need to continue these efforts and prepare for vaccination for potentially children age 5 to 11. Vaccines that could be authorized within the next month. We also know that there's been a significant drop in vaccination for routine childhood immunizations, along with well child visits during the pandemic. We haven't caught up with that yet, so we need to catch up on those routine vaccinations, ensure that every student has an opportunity to receive a flu shot this fall for a season that may be worse, in addition to dealing with the challenges around COVID vaccination. So put that all together, that's a lot in terms of vaccination strategies and challenges for the fall, made more pronounced by the many challenges that public health and school officials are having to face in responding to the pandemic and creating a more multi-factor and comprehensive approach to protecting children. So we're here today because we believe that school-located vaccination is a critical and proven tool for building vaccine confidence, expanding access to vaccines for those who need it most, and addressing these critical challenges. But we're also here today because we know that schools can't do this alone, and that it will take partnership and coordination between state and local public health officials, superintendents, school boards, school nurses, pediatricians, and the entire immunization community to make these vaccination clinics work. To support you in these efforts, we hope that we can bring stakeholders together now for a frank, up-to-date, and insightful discussion about innovative models and best practices, and work through some of those very difficult challenges that you're experiencing related to school-located vaccination. So go on to the next slide. I've given a little bit of an overview of why we're here and who I am. Our symposium co-sponsors include our group, the Duke-Margolis Center for Health Policy. We're very pleased to partner in this effort with the Association of Immunization Managers, who just have tremendous experience on innovative approaches to school vaccination, and the Rockefeller Foundation, which has been there from the start of the pandemic to help with addressing these unmet needs. So on to the next slide, just a quick review of the agenda. I'm going to shortly turn things over to Claire Hannon from the Association of Immunization Managers and Bruce Gellen from the Rockefeller Foundation now. We'll be providing some opening remarks on the challenges and opportunities lying ahead for public health and education officials in this space. Next, we're going to be joined by Dr. Rachel Levine, Assistant Secretary for Health in the Department of Health and Human Services, and Mary Wall, Senior Policy Advisor for the White House COVID-19 response team, as well as Dr. Tara Vogt, from the Immunization Services Division at the CDC. They'll provide an overview of critical data on gaps in childhood immunizations and discuss how the federal government is working to support vaccination in school settings. After that, I'm going to moderate a discussion highlighting innovative strategies and key considerations for hosting COVID-19 vaccination clinics in the K-12 school setting. Next, Claire Hannon is going to moderate a discussion on strategies and considerations for leveraging school-located vaccine clinics to improve routine childhood immunization rates. Again, they've lagged during the pandemic, and also to prepare for and be ahead of the coming influenza season. Then LJ Tan, the Chief Strategy Officer of the Immunization Action Coalition, will moderate a discussion on current research on parental vaccine attitudes and beliefs, as well as strategies for engaging families and building vaccine confidence. And I'm going to provide some closing remarks to wrap up our discussion at the end. So got a lot to get through. We're looking forward to a dynamic discussion. We encourage you at any point to use the Q&A function on Zoom to submit questions to our speakers and panelists. We're going to try to incorporate as many of those as we can. You can also use Q&A to make comments and share resources with our team and colleagues gathered here today. Hearing and learning from all of you about the work that you're doing, the challenges, the particular challenges that you're facing, how you're overcoming them is going to be critical to adding to our ability to take on these challenges in the fall. And then last, we're also going to have a survey opportunity after the close of the event. We're going to ask for more information from you on how we can best support you in these efforts. This is not the last step in the work that we're doing on this important topic. And finally, would like to let you know that we're going to have a recording available of today's webinar on our website for those who couldn't join in person. So to the next slide, to help set the stage, I want to provide a brief update on national trends and key issues for preventing COVID-19 outbreaks in school settings. As this slide shows, and as you all well know, we're seeing a big surge in COVID cases, hospitalizations, and deaths as the highly transmissible Delta variant continues to spread. And in particular, this wave is disproportionately impacting children and adolescents as we've seen more vaccinations and more immunity in the older age groups. In the past week alone, over 240,000 reported cases have occurred in children. There are likely several times that many more cases occurring in children, often with none or minimal symptoms, but still contributing to spread, still something we'd like to avoid. And right now, over 340 children per day are being hospitalized with COVID-19 in conjunction with this surge. On the next slide, the good news is we know how to deal with this. We have safe and effective vaccines. We have a number of other steps that can provide a multifactorial response and protection, since any one of these layers is not perfect. So vaccines clearly most important for those who are eligible, where the vaccines are safe and effective, people 12 and over. The most important thing we can do to contain spread in schools and community and protect against the consequences of COVID-19 is to help more people who are vaccine eligible get vaccinated. As I've said, we've got a ways to go in getting those rates up. Many schools are starting to require vaccinations, not only for their faculty and staff, but even for students, accommodating exemptions. Most other districts are strongly encouraging and trying to support vaccination. Along with that, there are a set of other tools that can add protection. They're on this slide. So masks proven quite effective. Regular testing strategy that more and more schools are using, since there's so much asymptomatic spread, and inexpensive tests where we've had a lot of experience are now much more widely available. Changes in ventilation to reduce the airborne transmission of COVID-19. All of these things can help reduce risk, and they're particularly important in settings, these other steps besides vaccinations, in settings involving kids under 12 who can't get vaccinated yet. On the next slide, we also know that schools have a really important and trusted role to play in communicating with parents about issues like vaccines and other steps to protect children. There's a lot going on in this slide, but I want to highlight these recent polls from the Kaiser Family Family Foundation, showing the importance of school communications. Parents' vaccination intentions for their children are largely correlated with their own vaccination status, with 6 in 10 parents who have received the vaccine saying that their 12 to 17-year-old is vaccinated, comparing to just 4%. That's 60% versus 4% for the unvaccinated parents. However, while a parent's own vaccination status is a good predictor of their intentions to vaccinate their children, we know that school actions can make a substantial difference. Parents whose children's schools provided information or encouraged vaccination are more likely to say their child is vaccinated, even after controlling for lots of other things, demographic characteristics, party identification, et cetera, that may urbanicity, that may also be associated with attitudes on vaccination. So again, a reminder that we need to do all we can to support schools as both an access point and a source of information on vaccines. So next slide. I want to share some of the resources that we've developed to help support school-located vaccination efforts. The Duke-Margolis Center for Health Policy, along with our partners at the COVID Collaborative and a number of education organizations, recently released this resource and issue brief that highlights innovative strategies for leveraging schools as COVID-19 vaccination sites. This brief also includes some case examples of innovative district-level approaches for engaging families, increasing access. We'll talk about some of these today. Please use this resource to provide some additional examples and guidance for you on what's going on around the country that can help address these challenges. So with that introduction, again, great to be with all of you. And I would like now to turn to Claire Hannon.
Thank you so much, Mark, and thank you to the event coordinators for this event. It's been amazing. We're just thrilled to participate. I'm Claire Hannon, Executive Director of the Association of Immunization Managers. And if you want to go to the next slide, a welcome from AIM. We are a nonprofit. We represent the 64 immunization programs that receive federal funding from CDC. 50 states, 6 large cities, and 8 territories or federated states. Our members work with all of you, all the stakeholders in communities, administering our nation's childhood and adult immunization programs, including COVID-19 vaccines. We work with vaccine planning, distribution, administration, tracking, all the routine activities, vaccine education, communication, safety monitoring, really representing the immunization infrastructure across the country. And Mark mentioned, the surge in cases in children, the Delta variant kind of setting the stage for today, but I just do want to celebrate our success in what we have accomplished. And 210 million Americans 12 years and older have received at least 1 dose, basically through this pandemic COVID vaccination infrastructure that we have set up. And we know that the next frontier, getting boosters and then getting children, younger children, is going to involve schools. Both parents and children have that connection through schools. And so we can use that to get more people vaccinated. Next slide. So why is AIM involved in advocating for school-located vaccine clinics? Well, immunization programs, again, are all through that immunization infrastructure, getting vaccines out. And school-located vaccine clinics have been a big part of this infrastructure and have evolved over time to be a great tool in the toolbox of public health to get vaccination rates up. We know that school-located vaccine clinics can increase vaccination rates among students and staff, improve community health outcomes, and increase access and equity for vaccines. For example, vaccinations provided at school-located vaccination clinics have had an impact on community spread of disease. A 2020 study showed an association between SLV coverage and decreased student absenteeism from illness and reduced influenza-related hospitalization rates for all age groups. We have a recent collaboration with the National Association of School Nurses to learn more about school-located vaccination. And in the coming months, we're going to be publishing these findings into digestible and actionable tools that you can use. In the meantime, you can find the report on the AIM website, and the link is listed there. Next slide. So just going over the role of immunization programs in supporting school-located vaccination. Partnerships are a key to success, and you're going to be hearing a lot about that today, taking pressure off of schools, school nurses who face competing demands. So the public health immunization programs are there to help coordinate some of the things that they do. They can provide vaccine, they can help with vaccinators, they can help make connections with local health departments. And there's been a lot of innovation that have grown school-located vaccination to make it more efficient, more sustainable, and some of this innovation you will hear about today. Next slide. So challenges and opportunities. So the COVID-19 pandemic has drawn attention away, I think, from some of the regular public health activities to combat influenza and other vaccine preventable diseases. Kids are falling behind on regular vaccinations. We know this, and we hope that schools will play a role, particularly now that schools are back in session, making sure that kids are vaccinated. COVID-19 really provides a unique opportunity. The infrastructure that has been built with the COVID-19 vaccination campaign can really lay the groundwork for improvements and increases and more robust school-located vaccination. For example, IT improvements, collecting consent forms electronically, scheduling and preparing clinics, reporting doses administered more quickly, enrolling tens of thousands of private providers, working with pharmacies, and having more robust relationships with communities, community-based organizations, and other stakeholders, hospitals, healthcare systems, health insurance plans. All of this has built a great infrastructure. So next slide, let me conclude by saying that, yes, we are all in this together. The ultimate goal is to keep children and families protected. And so I want to challenge each of us to see what we can do to support schools and school nurses in the community effort to vaccinate more kids, both for routine and for COVID. So I'm looking forward to the discussion today, and I'm excited to be a part of this initiative. Thanks, Mark.
Claire, thanks so much. Great working with you all on this. And now I'd like to turn to Dr. Bruce Gellen, who's the Chief of Global Public Health Strategy at the Rockefeller Foundation. He's leading work there on global vaccination, but has a tremendous history in impacting U.S. vaccination as well. Bruce, thanks so much for being with us.
Well, Mark, thanks a lot. Well, as I think many will figure out, that when Mark and Claire asked me to do this, it was a pretty easy sell. So it was great to be with all of you again today, and a chance to return to my roots on this important topic of school-located vaccination, which is one of the many topics the National Vaccine Program took on under the direction of the Assistant Secretary for Health and the range of partners both within and outside of government, the people who are assembled here today. But now I have the privilege of looking at this issue through the lens of a partner, the Rockefeller Foundation. And while I confess that a lot of this happened before I got here, that doesn't take me from taking credit for it, but really for what the Rockefeller Foundation has done. I want to tell you a few of those things and how those fit into what you're going to be talking about today. From the earliest month, Rockefeller championed this a national COVID testing plan that many of you have heard about, and to improve access to tests and treatments for all, with a specific aim of keeping schools open. And while now that we know that the demand for testing is soaring, the rates of infection, hospitalization, and death continue to climb, too much of this has continued to fall on society's most vulnerable communities. And people of color in the United States have been disproportionately impacted by this pandemic. And we still face barriers to receive COVID-19 vaccines, despite their supply and despite that they're provided by the government. And earlier this year, Rockefeller launched a $20 million Equity First Vaccination Initiative with the goal of demonstrating and scaling hyperlocal community-led programs to improve vaccine access and provide accurate information across 5 cities. In doing so, the foundation invested in localities, invested in community-based organizations with anchor organizations in Baltimore, Chicago, Houston, Newark, and Oakland, along with national organizations to adopt and then scale these learnings across the countries that we learned in these 5 cities. And by working with the people who know their communities best, big surprise, we can help to understand and remove these barriers to increase access to COVID-19 vaccinations in these communities of color and ensure that at least 90 million people of color are vaccinated by the end of the year. And by adopting this equity-first approach and working with the people who know these communities best, we can increase both the access to vaccines and the confidence in vaccines and the programs we have for millions of people of color. This equity-first approach was essential for schools, and Rockefeller has been doing this with schools to ensure equitable access to testing from the beginning. And now we hope to leverage this and apply it to the topic today of school-located vaccination. Just a few examples, but in Jefferson County, in Louisville and Jefferson County Public Schools started small to go big. In the spring this year, when district schools were closed, they launched small testing pilots across community learning hubs, the one place where students could gather in person to learn when their parents were unable to stay home. These small pilots enable them to iron out some of the wrinkles in small scale before offering testing across the entire district. And now they're leveraging the relationships they built here to think about and to begin to program the school-located vaccinations and testing as well. So this two-pronged approach, grounded in the trust of local communities and the partnerships and a can-do attitude, gives me hope and confidence that with our educators and leaders and all of you today, we're going to recover together and to be stronger. The person who I like to quote on this is Dr. Eva Stone from Jefferson County Public Schools, who said, "Students in, COVID out." I'm not sure that's the mantra of most schools, but it might be for this coming year. And while many schools in Kentucky are closed, schools in the county remain open. So it's a testament to proving things at a small scale. Our teachers, leaders, and school nurses are some of the best problem solvers in the nation. And this was the case, as has been the case in the pre-pandemic days, and is even more the case now. Their Herculean efforts today are what's keeping kids safe and keeping kids in schools and together. And so we owe you all for that. And thank you for being part of this pandemic response. Really, it's a movement that's focused on ensuring equitable access to quality safety measures to keep kids in school and COVID out. So again, Claire and Mark, thank you for having me. And I turn to the rest of your program and look forward to the lessons learned and the vigorous discussions you're going to have to be able to scale this and to do what you intend to do, is to provide access to vaccines in schools. Thanks.
Bruce, thank you, and thank the Rockefeller Foundation for helping to drive that schools in, COVID out movement. Great to see the progress. Still have a long way to go, but lots to build on. And I'd like to turn right to some of our federal partners who are going to provide a call to action on this issue and outline some of the key data that should help inform our efforts moving forward. First, I'm pleased to introduce Dr. Levine, Assistant Secretary for Health, who's joining us through some pre-recorded remarks for today. So let's hopefully go right to that.
Good afternoon. Thank you for inviting me to participate in this critical discussion. Now, I certainly recognize the importance of service and serving in this role. Throughout my life, I've really felt the call to serve and to help people. In my career in academic medicine, I served my patients, my students, and my staff. That's what we do in pediatric medicine. We help people. We help children, their families, our communities, and our nation. I want to thank everyone on today's symposium for your important role in helping our nation's children, as well as their families and communities, by educating the public and working in schools to increase support for all vaccines. In my role as the Assistant Secretary for Health, I work every day to improve the health and well-being of all Americans. And building a stronger foundation for immunizations is a very important priority, as vaccinations are one of our most effective tools in our public health toolbox. I also want to take a moment to thank everyone for your efforts to bring awareness to the need to augment routine vaccinations in both children and adults. They have slowed during the pandemic, and that has increased the risk for potential outbreaks. the Centers for Disease Control and Prevention previously released a call to action for children to catch up on missed vaccinations, citing a 14% drop in vaccine ordering of CDC public sector vaccines in 2020 compared to 2019. I find this data deeply concerning, and HHS has been working with state and local health officials, professional organizations, and other partners to reverse this trend in both children and adults. We continue to monitor the data closely, and we want to get out the catch-up message, especially as our children go back to school and ahead of the flu season. As you know, every one of us is healthier, and all of our communities are stronger when immunization rates are high. The fact is, vaccines work, and many serious diseases are preventable with vaccines. You will hear more today on catch-up vaccination for children and adolescents, including policy options, diversifying strategies, and other actions to address declines in coverage in children and adolescent populations. Across HHS, and with the help of a number of partners, we are working to increase vaccine uptake and confidence in vaccinations. I have personally met with a number of important stakeholders and have charged the National Vaccine Advisory Committee, or NVAC, to carry the catch-up message, and I encourage all of you to do so as well. I am here today to encourage the timely vaccination of students, as well as encourage educators and community leaders to leverage their trusted positions to help school boards and officials, as well as parents, on the benefits of immunizations and dispel dangerous misinformation about life-saving vaccines. Vaccines, when given on time, help to keep our kids in school so that they are not out on so many sick days, and help reduce spread of diseases further in the community. Now is the time to get all of our students caught up on their vaccinations so they are protected for the school year and into the future. We need your help communicating about the importance of immunizations and in bringing students up to date on their vaccinations. This pandemic has shown us that nothing is more important than the health of our loved ones. We can keep our children and families healthier and stronger by getting every child, teen, and adult caught up on routine vaccines that they may have missed during the pandemic. In conclusion, we all play a key role in helping our youth through this challenging time as parents, caregivers, educators, and clinicians. I know we can do better in this country and will work to do just that, learning from the past to build a better future. At the end of the day, I am motivated by being able to help people, and I know that everyone participating in this symposium is as well. We are all in a position to make a difference in people's lives, and we will face all of the many challenges together, working together to build a safer, healthier world for all of us. Thank you.
Well, I want to thank Dr. Levine for that clear call to action, and next turn to welcoming Mary Wall, who from the White House COVID-19 response team, who's leading a lot of the administration's work in this area. Mary, thanks for taking time to join us today.
Of course. Thank you, Dr. McClellan. And thanks for having me. It's so great to be here with so many people who are doing really terrific work on this issue. And so many partners. I know I've worked with so many of the folks who have been on the call, who have spoken on the call already, work, of course, very closely with our partners in Dr. Levine's office, at the CDC, and elsewhere. We're really, really animated about the idea that the best possible thing we can do to make sure that schools are staying open this year is getting every single person who is eligible to get vaccinated to get the shot. And so we've been trying really earnestly over the course of since the vaccine became available to age 12 plus, to really make sure that parents understand and have their questions answered about the vaccine, as well as to provide more and more access points in the community and wherever it's easy for parents and their children to access the vaccine. That, of course, means doctor's office and pediatrician's offices. That also means schools. And that's why we're here today talking about this, because we really want to make sure that just as parents and families see schools as such a key access point for so many critical services like food, like IEP services, like language services, that they also view it as a key place to get medical treatment, in particular, life-saving treatment like what we have here with the vaccine, with the COVID-19 vaccine, as well as to catch up on other vaccines where they've fallen behind. So I want to just say a couple of things about kind of our overall charge towards this, and then share some resources as well. We're currently in a place where it's about 43%, I believe, of our students age 12 to 17 nationally are fully vaccinated, and around 54% have received at least one shot. Of course, we're really happy to see that it's a majority now who have received at least one shot, but certainly there's more room to grow here. And students are still in this space of being furthest behind, though they, of course, have had the least amount of time, but they are the furthest behind in catching up with the older age groups. CDC has been extremely clear on this front about how life-saving vaccines can be for young people, in particular releasing data recently that shows that hospitalization rates are 10 times higher for unvaccinated adolescents than they are for vaccinated, fully vaxxed teens. And really trying to communicate this as much as we can and in as many ways as we can. In particular, we saw earlier this year in a bill, earlier today, we even had a conversation with a number of partners in school athletics, where we talked about the fact that there is that it's so important for student athletes to get vaccinated in order to safely play. We, of course, want to get everyone who is eligible to be vaccinated to get the vaccination. And the president has made really clear, starting over the summer, that schools can really be a critical access point. He made a speech in late July in which President Biden called on all school districts nationwide to host school-located vaccine clinics. And as part of that, we released a toolkit, a guide to on-site vaccinations at schools or in the community as pop-ups. I know it draws on a lot of the great lessons that we've seen from elsewhere, including from our partners at ASTO, from CDC. I know the National Association of School Nurses has put out resources, but really was a guide that we put out there to make sure that people understood this is the charge. We really want to make sure that every single school district is taking us up on this. And we also really want to be clear that it's not just setting up the clinic. And in some ways, that part is the easier part. And we've listed many ways in our toolkit that you can do this, including through the federal pharmacy program, which has enlisted all of these, the 40,000 federal retail pharmacies who are part of this program nationwide. And the president gave a special direction to them to work with schools on setting these up. Of course, you all know that our local and county health departments have been champions in also providing that access and coming on site at school, as well as HRSA resources in the community. So federally qualified health centers, school-based health clinics, and things of that nature, as well as doctors that can be found on vaccines.gov. But in many ways, that is the easy part, setting up the logistics for a clinic. It's really about, once you've set it up, really making sure that you can drive outreach and turnout for this. And that's in many ways the harder piece. We've provided a number of tactics and strategies that we think can work. I want to just highlight a couple of them that I've heard already, but identifying trusted messengers to really make sure their voice is getting out there. I can't say it enough with the younger kids or with teenagers especially. It's so important to be deploying teens to speak to other teens. We've seen really great teen vaccine ambassador programs across the country. And here at the White House a couple of weeks ago, we hosted a conversation with many of them, myself, Dr. Fauci, and the second gentleman, Mr. Doug Emhoff, hosted a conversation where we interviewed 6 of these youth leaders and talking about all the great things they're doing to get their peers to come out and get vaccinated. And a lot of it comes down to telling their stories. And that's so potent for young people to see. We've also enlisted the American Academy of Pediatrics to partner with the National PTA to allow any PTA nationally or other parent association to reach out to the AAP and request a pediatrician, a local pediatrician, to come to their meetings and talk about the vaccine. Again, empowering people with as much information as we can. We've released toolkits for faith-based organizations and community-based organizations to facilitate conversations on the vaccine. We've also provided materials for school districts, teachers, labor partners, and unions to similarly engage students and families. And of course, we've also looked at this as a way to use creative incentives to encourage people to be involved. The American Rescue Plan provided, among many other funding streams, including money for testing, and I was very happy to hear the testing money be mentioned here as well, but we've provided $130 billion for school districts across the country, states and school districts to provide for a number of items related to safe reopening. Vaccines certainly fit in that category, and we really want to make sure that people understand as well that they can use their federal stimulus dollars to provide reasonable incentives to students and families to get vaccinated. And this is just such an enormous thing that I know people have been thinking very creatively in getting their students to be involved. So I'm hopeful that people will do that as well. And as I wrap, I just want to really quickly, if I can, share my screen so that you all can see some of the materials. In particular, this back to school toolkit is what I was referencing before. It is full of a lot of different resources and materials. Can't tell if I'm just
Mary, I'm not sure if what you're projecting is up yet, though it does show you started screen sharing.
Well, can you still hear me?
We're happy to provide the links too, if that's helpful.
Sure. Yeah. That would be great. Can you still hear? Oh, there it goes.
Yeah, I can still hear and see you.
Apologies, my computer acting up here. I will provide the links, Dr. McClellan, thank you. It has I just want to really make sure people understand what we have, and it draws from and links to a number of other resources that have been provided here. But it provides by heading here stuff for school, resources and materials for school leaders, for teachers, parent leader association, meeting in a box toolkit, ideas for school support staff, talking points for school support staff like secretaries to be able to engage with parents when they call and ask about things related to the vaccine. We really want to completely surround sound on this. And there's also a link to the on-site vaccine toolkit, which is our partner guide with the federal pharmacy program that lists specific individuals that you can reach out to at any of these providers. So that could be Kroger, Costco, CVS, Walgreens, any of these, to directly request that these providers come on site in your school to facilitate a vaccine clinic. So I will end there and I will send these resources along as well. Thank you.
Thanks so much. We'll get links to all those resources out. Really appreciate your time with us today and all of your leadership. And now I'd like to turn to Dr. Tara Vogt.
Okay. Good morning and good afternoon, everybody. I'm very happy to be with you all today and to be part of this conversation. So let's just jump in and go to the next slide, please. So my presentation today will focus on the impact of the pandemic on childhood vaccination. And I'll also talk a little bit about overcoming barriers with school-located vaccination as a key strategy. Next slide, please. And next slide, please. So at CDC, we typically monitor childhood vaccination coverage through large national surveys of parents, guardians, as well as analyses of state-reported vaccination status upon entry to kindergarten. But in both cases, there's a time lag in terms of availability of the data that's not conducive to real-time monitoring in the setting of a fast-moving pandemic. So for this reason, we have turned to looking at trends in orders of federally supplied vaccines for children, or VFC vaccine, which is provided at no cost to eligible children, which are mostly Medicaid enrolled or eligible, and represents about half of the vaccines administered to children in the US. So these are the data that Dr. Levine had mentioned in her pre-recorded remarks. And so on this figure from the May 2020 MMWR publication, it shows this sudden decline in all non-flu vaccine doses and measles doses ordered compared to orders from the previous year. So this decline started just about when the national emergency was declared in mid-March, and it was a real red flag in the early days of the pandemic that something dramatic was happening. So next slide, please. So we have continued to track these data, and you can see that the decline was steepest, in that first month or so after the national emergency was declared, but it has started to moderate. The line has flattened some, which is good. And it's been picking up recently, which is also really good, but not quite enough to make, well, not at all enough to make up for low ordering earlier in the pandemic. So we are currently down about 12% in terms of VFC ordering compared to 2019. And I also wanted to mention that we do look at orders for individual vaccines. And so those for adolescents have declined more dramatically than those for infants or in younger children. So it seems that these older kids are not getting their well child visits or checkups, or missing their routine vaccines more often. So next slide, please. I also wanted to share quickly the COVID-19 vaccination coverage for adolescents and adults as of the 14th. I pulled these data down from the CDC COVID data tracker. So the bars on the left represent the coverage with at least one dose of COVID vaccine, and on the right, you'll see coverage for being fully vaccinated with COVID-19 vaccine. So clearly the coverage, as has been mentioned, among children ages 12 to 17 in the blue and green bars is less than ideal and substantially lower than coverage for adults. So, this is concerning, especially given schools are obviously back in session across the country. Next slide, please. So why exactly have we seen such declines in routine pediatric vaccine orders and likely administration too? Well, CDC and others have conducted a good number of investigations and assessments into the possible barriers, and some of the bottom line results are on this slide. And they include provider offices being less available to pediatric patients, especially this was so earlier on in the pandemic, not as much currently, thankfully. Parents being reluctant to take kids to get preventive care out of fear of exposure to SARS-CoV-2. Parents just not being aware that vaccines or well child visits are due or overdue. And then finally, and not surprisingly, school vaccination requirements not being as strictly enforced last school year compared to previous years, just due to the competing priorities and severe challenges that COVID has thrown at schools. So some of these barriers are also likely at play for COVID vaccination, along with a host of other ones, such as parent concern and around the safety and effectiveness of these new vaccines. Next slide. Okay, so now let's talk about some solutions. Next slide. So I'd like to talk about the solutions in the context of what CDC-supported state, local, and territorial immunization programs told us they were doing or planning to do in order to enhance routine childhood vaccination catch-up. So on the slide, you'll see their responses to a May survey ranked in order of frequency of report among the 48 that responded to the survey. And so they will work on ensuring school requirements are met, communications and other things. But importantly for today, a full 52% reported that holding SLV clinics routine catch-up was underway or being planned. And that, and this does not even include, the plans for COVID SLV clinics, which surely would have made it higher. So Next slide, please. So I also wanted to mention some interesting unpublished results from a survey of a convenient sample of National Association of School Nurses members that was conducted in collaboration with NASN and the National Foundation for CDC. So among 977 school nurse respondents as of this May and June, 45% said that SLV for whatever vaccine was likely to occur in their school this school year. And 23% said they were not sure or was not yet decided, and then only 31% said it was unlikely. So the breakdown of vaccines that might be offered in these clinics is on the right. So over half would offer flu and COVID vaccines, and then fewer would offer routine non-flu vaccines. Next slide, please. So the results on this slide come from that same survey of school nurses. And so here you can see that a majority of school nurses are supportive of SLV at their school for just about any vaccine, including COVID vaccine for eligible family members of students. So that was also encouraging. Next slide, please. Next, I wanted just to briefly plug our CDC SLV considerations document that was posted on our website this spring. So there's some practical information included in this guide, which was designed to be applicable to routine childhood vaccination as well as COVID vaccination, though there's a special consideration section specifically for the challenges of COVID vaccination. Next slide, please. So this guide also includes several modifiable template communications for principals, parents, healthcare providers for different aspects of implementing SLV for COVID or routine vaccines. There's also a companion piece that our CDC school group put together, which talks about how schools and the education community can help support COVID vaccination. There are also some fun things included, like some lesson plans and success stories. And we also have some good school-themed communications products promoting COVID vaccination among adolescents that could be like hung in schools or sent home to parents and promoted via social media. Next slide, please. So because we've been talking about routine and COVID vaccination, I wanted just to say a brief word about co-administration. So COVID vaccine can be co-administered with other vaccines, including flu and routine childhood vaccines, without regard to timing. There are no safety concerns for co-administration, and there may be very good reasons to do so, namely to avoid missed opportunities. Because you have kids right there present, it's good to get them fully caught up with all the vaccines that are recommended. However, it is acknowledged that we don't have data to support this, but parents may be reluctant to agree to co-administration. So this could impact SLV planning. At CDC, we're working to learn more about parent attitudes and preferences related to co-administration. So next slide, please. So in conclusion, many school-age children and adolescents missed routinely recommended vaccines over the last year and a half due to COVID-related disruptions, especially concerning our measles vaccines because of the potential for outbreaks, like we saw in 2019. And then adolescent vaccines because they are challenging even in non-pandemic times. And then of course there's flu and COVID vaccines which are both really critical to keeping kids in school. So school-located vaccination can help kids get vaccinated so they can be protected from vaccine-preventable diseases and can stay in school. So next slide, please. And this is just an acknowledgement of my CDC colleagues that have helped. And then the next slide is just thank you and best of luck to everybody in your endeavors as you consider or actually implement SLV. So thank you.
Tara, thanks very much for that comprehensive presentation about where we are and where we're headed. Very helpful as we go into this discussion. And I thank all of our federal partners for taking the time out to join us today. Now, we are running a little bit behind. We're probably going to go into our break by about 5 minutes, so shorten a little, which should still leave us with plenty of time for discussing some key issues related to rising to the challenge, the innovative strategies for mobilizing K-12 schools as COVID-19 vaccination sites. We've heard a little bit about this already. You've seen some resources or have links to resources, but I'm pleased to be moderating this discussion to have some opportunities to directly share experiences with mobilizing schools as COVID-19 vaccination sites. We're very aware of how different each school district is in the United States and the special circumstances that presents. As we talked about in our recent issue brief, there are a lot of approaches that have been used to host vaccination clinics, some using health centers, some using other partners. Mary talked about pharmacies and other approaches as well. There's not a one-size-fits-all approach. You're going to hear about some different approaches and the logistical issues involved and how to overcome them from our panelists who have all been working hard to support COVID-19 vaccination clinics in their own states and communities. We've asked them to give about 5 minutes of opening comments about how they've operationalized these efforts, worked through the challenges, what they've learned, and then we're going to have some time for discussion. Please send along any Q&As or comments that you have. Our panelists include Tiffany Tate, Executive Director of the Maryland Partnership for Prevention, Sarah Regal, who's Health Services Administrator for School-Based Partnerships and Child Care Health, and Caitlin Miller, Program Manager for COVID-19 Program for Public Health in Seattle and King County. They'll be presenting together, and Gabriella Blakey, who's Chief Operations Officer of Albuquerque Public Schools. Again, thank you all for your taking time today, and I'd like to first turn to Tiffany to talk about the Partnership for Prevention's work with schools in Maryland. And Tiffany, I think you're on mute still.
Great, thank you so much. Good afternoon and good morning to some of you. It's really nice to see you and to be here to talk about something that we've been involved in for quite some time. We can go to the next slide. I'd like to talk about sustainable programming in school-located clinics. So just a little bit about our organization. We're the Maryland nonprofit, the Maryland Partnership for Prevention. We're a nonprofit and we've been around since 1999 as an immunization coalition for adult and childhood immunizations. Historically, we provided technical support and training and educational opportunities for immunization stakeholders. And about 7 years ago, we got into the business of providing school-located vaccinations. And initially we started in response to health departments' need to have support to administer flu vaccinations in schools. And we quickly learned that our model also applied to other vaccinations. And so we administer about 30 to 50,000 vaccinations a year to children and to staff and faculty in schools. We also administer vaccinations in long-term care settings, churches, employers, and other community settings. And we also are a distributor of vaccine technology and testing technology that supports our work. Next slide, please. So what we do is just go into the schools. We have strong partnerships with the schools and the school leaderships. None of this could work if you did not have strong partnerships. And so partnerships are more than just writing your name on a paper and signing off on something and having your name posted on a website. It's true partners where all of the roles and responsibilities are defined. And so we have clearly defined roles for all of the folks that you, or the entities that you see listed here. And that's how we're able to sustain our programming, by having substantive partnerships where everyone knows what their roles are and are committed to that. Local health departments are involved, the state health departments involved, local coalitions, parent organizations, and also the general community. You can go to the next slide, please. So this year, what we're planning to do is just offer COVID vaccinations and flu vaccinations together. And so historically, during flu season, we go in, we vaccinate 5,000 students a day. We have a number of teams that we deploy, and they go into dozens of schools. We vaccinate students, and we just go back every day until everybody's taken care of. And this year we'll be administering COVID vaccinations at the same time as flu. In the springtime, we offer what we call back to school vaccinations. So we offer Tdap and meningococcal and HPV vaccines in middle schools. And so at that time, we'll also be offering COVID vaccination. So our approach is just to use our existing model to offer vaccines to bring children up to speed, up to date on their general vaccinations, and also offering COVID vaccinations and flu vaccinations when it makes sense. But in order to make this work, you also need buy-in from the community. So providing education to let people know why vaccinations are important, that children have fallen behind because of COVID and other reasons, and that it's really important to be vaccinated, and that it's okay to have these vaccinations at the same time if you're offering more than one type of vaccine in a clinic, to market your activities and also to provide other resources to support that. It's also really important to have a skilled clinical team. When you're offering multiple types of vaccine, if you're offering these back to school vaccinations at the same time that you're offering COVID vaccine, you need to make sure that your team understands how to administer the vaccine, how to mix the vaccine, how to make sure you're not administering vaccine to the wrong person. One family might have approved for their child to get back to school vaccinations, but not COVID, or vice versa. So we need to make sure that that's taken care of. And so there's a lot of training and logistical things that are involved in being able to pull off these types of partnerships, and also having general clerical support to move things along. The next slide, please. The other things that make this work is technology and automation. So about 4 or 5 years ago, we came up with a product that automated the consent form and also the clinical management. So tracking inventory, documenting the vaccine encounter, and reporting that information. And we saw a 50% increase in participation when we moved to this model where people could fill out the form online. And so we've seen it increasingly during the COVID, that people are more savvy with technology and expecting technology. And so to be able to make this work and remove the administrative burden of data entry and photocopying a bunch of papers and forms and getting them out and collecting them, instead you can do this electronically. And we created a system for our own personal use about 5 years ago, and now it's being used during the pandemic. It's called PrepMod. Some of you may have heard of it, but our PrepMod system can also be used for school-located vaccinations. It can be used for flu vaccinations or combination clinics. So it's really important to have technology and use that and leverage that where you can. We also have a system called PM Schools that allows schools to schedule these types of clinics, and also it tracks staffing and does timekeeping. And so these administrative activities are really burdensome when we're thinking about having school-located clinics. And so we've created technology that automates that and makes that easy. That is something that deters people from having these types of campaigns. Finally, reimbursement. So now there's a lot of money flowing to be able to fund these types of activities, but we're always thinking about sustainability. And so you need to have a mechanism to be able to collect insurance information and to bill insurance information. And out of need, we also created a tool. And so this suite of services that we've been using, we make available to others. But in order to have sustainable, successful campaigns, you have to be able to automate things and make it easier for people, and also identifying ways that you can keep these going, because it threatens the confidence that the community has in public health if we start things when the money is flowing and then it goes away afterwards. So I think that's the end of my comments, and I'll be happy to participate in answering questions when the panel starts. Thank you.
Tiffany, thank you very much. And I'd like to turn next to Sarah and Caitlin from Seattle and King County to talk about their school-based vaccination efforts. Thank you all. And be sure to unmute.
Sarah and I are playing a game of chicken right now. Who's going to talk first? And I'm going to make Sarah.
No, I'll go ahead. Thank you. And luckily, Caitlin and I are two people who talk really quickly, so they may be for the benefit of getting back on track. But we have a lot to share, and what I'm going to do is frame a little bit of the context at our health department and sort of how we got started with our vaccine work for schools, and the history that's important to, I think, part of the successes that we've had is really about the relationships that we have with school partners across our region. We are the largest county in our state. We have 19 school districts and 216 independent schools in K-12. So we're pretty large. Our largest district, Seattle Public Schools, has 55,000 students. So across our state, we've been leading this work. Public Health Seattle and King County created our school-based partnerships program, which I lead. And prior to the pandemic, we have 35 school-based health centers that we support. Also a childcare health consultation program that's part of my work. And so it was pretty natural that at the beginning of the pandemic, I stepped into a key role to support schools with the immediate implementation of their mitigation strategies, especially childcare and schools while they remained open, while we became an epicenter very early on in the pandemic process. So we established that task force in February of 2020. And right around that time when schools closed, we played a key role in supporting the implementation of those mitigation strategies, writing guidance where those things didn't exist, where we had CDC on the ground with us in those very, very early times. I pulled Caitlin into that work as well, and we created a multidisciplinary team that was our task force. Our school-based health centers, like I said, 35 of them, really only closed their doors for a short period of time in the spring of 2020, and all reopened early in the summer of after that, and remained open during the time where schools were closed. So they were really the only access points and the only school partner that were allowed inside buildings during the largest portion of our shutdown. And they were able to continue to provide services for students, really focusing so much primarily on routine immunizations, meeting students in the park, outside, often going to students' homes, and just wherever people were comfortable, using, again, the established relationships that they had with families and as their primary care providers to support the continuation of routine care. And then as vaccine became the primary mitigation strategy for staff, when our teachers became eligible for vaccine around April, I think, end of March or April, we pivoted a bit more to linking with our vaccine team, who was already doing some of this work for adults. Caitlin moved to a full-time position on the vaccine program, so we continue to use our task force as sort of this hub and spoke model where schools have really a one-stop shop and no wrong door to access all sorts of information about the resources that they needed to support their schools and communities. And so vaccine just sort of became a natural next step in terms of our strategic approach to supporting schools across the pandemic. I'll shift to Caitlin now to talk a little bit about what that vaccine work looked like, and then also look forward to questions later.
Thanks, Sarah. The Schools and Childcare Task Force that Sarah is mentioning right now, as she said, is a really critical core to our work, and vaccine has become a major offshoot of that. And when we were aware that vaccine was going to become available and that likely school staff, childcare staff, were going to be prioritized in the rollout, we really started to pave the path early and ask for schools to identify whether they would be willing to host school-located vaccination clinics when the time arose. So by the time that effort came to fruition, we already knew who to talk to, where we could go, what their capacity was, and it helped us mobilize our vaccinating partners to get clinics up and running right away. So I believe at the time, I can't even remember the date at this point, when people 12 and older became eligible for the vaccine, we didn't have a lot of time left in the school year here in our region to really make this happen. And so within a week, we had events already popping up. We are working with a lot of pharmacy partners, with our EMS, emergency medical providers, our fire departments, and continue this partnership now into the fall. We were really, really grateful for that partnership to have over 110 clinics pop up in the spring in our 19 school districts here in King County, serving about 15,000 students with first dose vaccines. And many of these were open to families as well as community members as well. This summer, we've really focused on other youth-focused events in the community, reaching people where they are, catching them up with routine vaccines as well as COVID, making sure that we have partners that can do both our vaccines for children, administered vaccines, as well as COVID vaccine, and building capacity, as Mary mentioned earlier, of really having teens and young people talk to their peers about why it's important to get vaccinated, not just for COVID, but for other vaccines as well. We're also working on a really robust pediatric referral system, making sure folks have a place in the community to go to for routine care, well child checks, as well as COVID, supporting our vaccines for children providers to ensure that they can also provide COVID vaccine. And now in the fall, we're really focusing on catch-up events. What we paved the way for in the spring is continuing into the fall and making sure that we have at least a few events in many of our districts where the needs are highest for both COVID and flu co-administration. And we're prepping for the EUA. As was also mentioned earlier, we're really trying to do what I call the pre-work and making sure that families have opportunities to learn and ask questions in the lead up to any clinical services provided on campus. Because we know it's not just about having the clinical service there, it's about having the conversation and the confidence to really move forward with making that decision for your family. I will end there and pass it on to our next panelist.
Great. Thank you both very much for that concise dual presentation on the Seattle-King County experience. And next, I'd like to turn to Gabriella to talk about the Albuquerque Public Schools COVID vaccination efforts. And Gabriella, I'm on mute too.
Thank you, and thank you, everybody. This presentation, from my perspective, is actually looking from the school district's perspective of partnerships with COVID vaccines. Our school district is about 75,000 students in 143 school sites. And I have to say, I'm really proud to be a part of New Mexico, where I think that as a state, we quickly moved forward with COVID safe practices and getting immunizations out in a very effective way in a state that could have turned a different way if we didn't have all of these partnerships and the leadership of the state. Next slide. So as a district, we use the guiding principles and values in moving forward with COVID vaccines, looking at access, trust, and community. And I think this has been talked about over the course of the morning, but really in effect in Albuquerque Public Schools, we looked at access as far as increasing access to vaccinations to our community. We have a very diverse community that is rural and urban, and a lot of poverty in our state as well. And so looking at access was really important for us in our community. Trust, we looked at as one of our guiding principles, because as a school system, we often have trust in our families as far as using the facilities and communication that's trusted between the school site and our families, that we were able to really leverage to bring families in to get vaccinated by using our facilities and communication through the school district. And overall community, I think, as everybody has spoken about, without our community partners, we really wouldn't have been able to respond to this public health crisis as a united front. And honestly, for my role as a chief operations officer, it was really kind of moving some red tape out of the way to give access to our families and to the community to be able to use our facilities and to increase our vaccinations. Next slide. So what did we do? We worked to distribute about 40,000 vaccines for our community within the Albuquerque Public Schools facility sites. That's just a fraction of what our state was able to do. We contributed to the 8th highest vaccination rate in the county, in the country, with our county, specifically of Bernalillo County, where Albuquerque is located. We're about 72% fully vaccinated. We had 10 sites within our schools that we opened, and we also opened up our stadiums for drive-through clinics as well. We worked to, we have about 12,000 employees, and so we facilitated access for making sure our employees were vaccinated prior to our reopening of school in spring of last year. And then we had about 37,000 eligible students that we facilitated getting them appointments and making sure they were vaccinated. We also had a really good, and we continue to have a great portal through our Department of Health as a state. And what we were able to do is really leverage the use of the portal with our families, our students, our staff, to publicize the use of the portal and making sure that it was communicated so that everybody had access to get registered and to get vaccines. Next slide. So this really started in December of 2020, and we looked at a partnership with our city, the Emergency Response Department, and the New Mexico Department of Health. Our school facilities were closed because we were in remote learning, which had an opportunity to be able to open large sites for vaccines because we didn't have them open for schools. So in this first phase, we looked at weekly vaccination hubs, and we opened 4 high school sites. They were our largest facilities, obviously, that most people were familiar with how to get there. And we opened them up for vaccinations for the community. At that time was phase 1 for New Mexico. And then our school nurses, since we were in remote learning, they were able to come in and assist with the distribution, which really helped increase the effectiveness of our Department of Health to get vaccines out with an increase in the number of people that could help. We used our maintenance and operations department to set up all of the vaccination sites, as well as provide cleaning during this time. And then we used our school police to assist in all the traffic control. Next slide. This is just an example of one of the sites we used, our professional development site, as a vaccine distribution site for the city. And we just kept it open because at this time it was kind of something positive we could use by our facilities being closed and not being able to bring groups together, as we have a fabulous professional development site that was closed for conferences, but we quickly opened it and just kept it open as a vaccine distribution site that was used over the course of the past few months. Next slide. Phase 2, we moved into in about March. Again, phase 1, we started in December. And this was when our employees were eligible for the vaccine. And so because we had these partnerships and we had already been doing these sites, it was really easy to quickly adapt to the next phase of our employees being able to get appointments and teaching them how to use the portal from the state and making sure that they're getting their vaccines, making their appointments and everything. And we used several partners throughout the city that we used as vaccine providers and made sure that all of our employees were vaccinated by the end of March. Next slide. And then our last phase 3, which we kind of continued to be in, was including students age 16 and above for vaccinations. We prioritized our seniors so that they could be vaccinated before they graduated. And then we phased in students 12 and above as the vaccine was approved. And then this also led to working with the Department of Health to open up our schools for the Back to School Got Shots clinics that they provide for students for all the adolescent vaccines. And since we had this kind of already going, it was really easy to be able to adapt our schools to provide all of the back to school vaccinations and help our students catch up with their vaccines. Next slide. And just real quickly, the lessons that we learned through this and that we continue to learn as we work to keep providing vaccines to our community is trusted facilities of our schools being opened up, and communication led to building vaccine confidence across our families. It was partnerships were essential. You know, we're the school district. We relied on our Department of Health and all of the community partners with a common goal of just getting our community vaccinated, and having that partnership was really important. And using each partner's expertise was important, that we all had this shared goal, but all of us brought something different to the table. And we just leveraged the expertise of each of the partners to quickly adapt and get the vaccines out. Again, this led to us opening our schools very quickly for the Got Shots clinics from the Department of Health, and also increase the distribution of flu vaccinations, which we're in now. And everybody just keeps asking us, okay, so when do we do flu vaccinations? And now we're able to really build up that vaccine confidence and get our community healthy. And that is it for mine.
Great, Gabriella, thanks for, and all of you for some very informative, packed presentations. We do have some time for discussion of these experiences now, and making sure that we're addressing questions or concerns that you all may have, things that you'd like to follow up on. Again, please use that Q&A function to put in any question, add comments, or otherwise enrich this excellent discussion. But let me start, if you all don't mind coming back on camera. In all of you highlighted the need for a collaborative approach to implement these programs effectively. Obviously, schools involved, public health involved, pharmacies or other healthcare providers involved. Could we talk a little bit more about the community partners? All of you mentioned those, but that's a potentially very diverse set assistance with connecting with people, getting trust and engagement out there in the community. And I wonder if each of you might have a few words about particular community partnerships or approaches to engaging the community that have been really effective in your work. Gabrielle, I see you on screen, if you don't mind.
Sure. In Albuquerque, particularly, we have a robust set of community schools in our schools. And so we really leveraged partnerships with our community school coordinators to get out to the community that they serve information, let them know when the clinics were, bring them to the clinics. And we, worked to translate into, I think, 27 different languages, flyers, the permission slips, everything we needed. And so we really worked to leverage the partnerships that we already have established through mostly our community schools partnerships.
Thanks. Others want to comment?
I would add the same, all the things that we've mentioned, the existing relationships, I think were very much key to starting up all of the work we've been doing with schools, but building more that didn't exist, and also utilizing other community-based organizations and other resources that I think emerged in the COVID response more broadly. In our emergency response system, we set up a community mitigation branch, which is now Community Mitigation and Recovery. And when that group formed, it also had really other sector-specific task forces and community-based task forces. So, for example, Latinx community or faith-based organizations or other places that, although school is a natural place, it is not always the first place. And especially during this time, it wasn't the place that some families felt was safe, or that school was not necessarily a trusted community. So we used other trusted messengers and other community folks to draw people back towards school as a centralized location, because physically and geographically, school seems to meet a lot of people's needs, but it may not have been the first place that people thought to get information or vaccines from.
Thank you. Tiffany, anything you'd like to add?
I would like to add that when you explore these community partnerships, one of the most important things that we found is having the partner responsibilities delineated and written out. So we have a document, a 2-page document that lists what the school health department, what the school health group will do, what the health department will do, what the parent teacher association. It's sometimes we assume that everyone knows what their role is, but sometimes they don't. So when you engage in these partnerships, particularly when you're having such a logistical rich initiative, that you need to make sure that everyone's very clear on what they're doing.
Great. So thanks for those additional insights. We've talked a lot about your experiences so far, which no question have been challenging with the midst of the pandemic and the new developments related to COVID vaccines for adolescents. I'm wondering if we could spend a few more minutes looking ahead. So coming soon, the next month, are potentially the authorization of the first vaccines for children aged 5 to 11. Wonder if you all could each comment on how you're planning for that. Is it going to be different in some ways from what you've done so far? What are the new considerations?
I'll start with, we have already a very robust existing program where we go into the schools and administer flu vaccinations in the fall and back to school vaccinations in the spring. So we've got all of that already laid out, and we just intend to add COVID vaccinations. And because this is a new thing for us, we'll be refining our process as we go along. So we're excited and nervous at the same time about how this will work to offer COVID vaccine in the clinic, and how do we identify who's signed up for what. But if you already have an existing infrastructure, it will be interesting and informative to see how you add COVID to the mix of vaccines.
We've started to look at it and be ready for our younger students. I like earlier the slogan, I guess, of the students in, COVID out, that I think would be helpful in us as we look at our younger students. And ours is a little bit different because we used hubs basically as central locations around the city. And looking at our younger students, we're seeing more of a need to go to the school. Like Tiffany was saying, to actually go on the site to give the vaccines for the younger students, and knowing that most of them, if it's similar to what we've done with the flu vaccine, they need their parents to be with them. And usually we need to do them at the end of the day. so that the other students don't freak out when they see younger students crying. So just because of the age group, it's just a different age group than trying to get our 16-year-olds in. So I think that ours is adapting a little bit more to smaller number of students and going in. Again, we have over 90 elementary schools. So looking at how we can facilitate that is something that we're starting to look at.
Thanks. Caitlin?
It's kind of an inverse situation for us here in the Seattle-King County area. Similarly, we have many, many more elementary schools than we do middle and high schools. The challenge is they're very small. And right now, as we see the EUA coming up, the potential for boosters, third shots going on, and a very, very strapped medical system here locally, we're having to figure out a more hub-based model. Whereas before in the spring, we had the capacity to really be in many, many high schools and middle schools. Consent is definitely an issue here. It's changing our timing. While we could have and rely on older students to bring consent forms or be a little bit more tech savvy to do online consent or phone-based consent with their families, we don't have the same resources and opportunity for our younger students. And so it is, as Gabriella mentioned, we're looking at events later in the day, on weekends, that could really draw people regionally to sites. But it's hard to say, and it's going to depend district to district, because at least in our region, we have vaccination rates for our adolescents right now ranging from 54% to over 95% between our 12 to 19-year-olds. And so really trying to focus with an equity-based lens on where we drive these resources that are continuing to get more and more strapped as Delta makes its way through. But it's definitely shifting our approach for sure, working with our younger groups.
That's very helpful. Thanks. Looking through we got a number of good questions, and thank you all for submitting. None of them relate to kind of picking up on what's different from doing school-based vaccines clinics in this context versus in the pre-pandemic context. So one of them is about, people are resistant, not only now but before, because this is an added logistical burden. I think you may have mentioned kids, Gabriella, maybe kids crying during the day, and that's disruptive too. What have you found helps? Are there issues that are different now, and what do you find helps people overcome the reluctance, maybe engaging and getting these clinics in place?
I think part of ours is, we do have our, public health order and how we navigate students who are positive, like close contacts. If they're vaccinated, they can stay in school. So we look at some of that as far as like prioritizing in-person learning and what families can do to keep their students, safe and be able to maintain in-person learning. So as a people back, we also look at events, because then it's, something positive. We find that most parents that are not necessarily wanting to get the vaccine, then those are the students that aren't getting the vaccine. So we're trying to look at how we can do positive family events as well. We're doing one pending the approval for our younger students at the zoo, where they would be able to go in and go to the zoo for free. It's also a distraction from the little ones after they get their shot. But looking at like positive ways, keep pushing hesitancy and building up confidence for the little ones and their families.
Any other comments on this one? What's different now?
Well, I think there's a lot that's different. One of the things that we're excited about is that the schools have had to be so flexible, and they already have been experts in making decisions on the fly just because of the nature of their industry. But now we're looking to them to figure out the most appropriate ways to educate families, to reach out to families, to secure consent. The schools have had to evolve their processes with the pandemic. And so while we've been in the thick of it in terms of helping with vaccinations, the logistical concerns that people think about, and just how do we relate to families, how do we educate them. We can rely on the systems that have been evolving during the pandemic that the schools have been relying on. So we've always viewed them as a really strong partner, and now even a greater resource. And I encourage folks who are looking to work with the schools to rely on them to answer some of these questions, because we can guess and make the wrong decision and end up wasting time. I just go to the schools and say, what are you guys doing? What do you think and what's working?
Thank you. Caitlin, is there anything else to add?
I would echo what Tiffany just mentioned. Yeah, it's just, I think really letting the districts drive and dictate what the needs are in their communities, principals, other leaders, parent-teacher associations, and others, and really helping that define and guide the work that's happening in these SLV clinics. And not as the health department coming in and saying, thou shalt do these things, or we expect you will do this. They really are in the driver's seat and are working in tandem as peers to their vaccinating partners. Safeway, Costco are our two big ones, and others. That is really what makes this tailored, and focusing also on what I call this pre-work, which is those conversations in those spaces that are trusted and known in those communities, and having that be a bulk of the work, a focus of the work beyond just the clinical service.
Yeah, I was just going to add too that this is the first time we're able to say yes to a lot of the requests that have. So historically, we haven't provided a lot of school-based vaccine clinics, at least from the health department's perspective. We're doing it in our school-based health centers. We're doing, some districts are doing sort of contracted support just for flu. And they consistently ask us for decades, why won't you come to our school and do all the Tdap? And we just haven't had the capacity to do it. So for the first time, we say yes, and we're able to link lots of vaccine partners together and make it possible. And I hope it's something that we can continue to sustain and learn from for the future as well.
Yeah, if we have time, it'd be good to hear from you all about how you're planning to sustain all of this, or what might be helpful in enabling you to sustain these new efforts. I did want to pull together a few more questions from a great set that we have that are in one way or another related to equity issues. Now, you all have touched on this, and the importance of community outreach and trust, and some steps that you've taken to do that. Maybe if you don't mind, can you expand a little bit on that? Any steps that you're taking to track vaccination in ways that address equity and respond, or other indicators that you're using suggesting that more outreach efforts may be needed? Gabriella, I saw you got a call out for some of the work you're doing with Indian Health Service in the Albuquerque area, but any thoughts about additional guidance on addressing these kinds of equity concerns?
Yeah, I would say, one of the things our health department has excelled at extremely well in this last year. First off, our director declared racism as a public health crisis very early in this pandemic period. And we've continued to sort of live that through our emergency response and our community mitigation branch, especially in our strategies around all sorts of implementation of the pandemic efforts. So with that, it's really, as Caitlin alluded to, looking at our county, which is geographically pretty large and also quite diverse. So as she said, the rates of vaccine and even the rates of COVID and all sorts of things are really following the demographics in our community, where the southern part of our county has the greatest number of disparities. And then to the north and east, we tend to have more homogeneous populations with higher rates of vaccine and lower rates of COVID. And so we are looking deeply at the data in order to figure out exactly where we should be focusing our efforts. Now, for school districts, we're doing the same, but also making sure that our resources are, well allocated, that are not always focused in our city, which tends to get the greatest attention for the majority of the population in our community. But making sure that we're reaching all parts of our county. We have a large city. We also have some very rural areas to the east as well that have different political viewpoints, and really just trying to manage all that diversity in an equitable way. Caitlin posted a link to our vaccine dashboard, which I think is kind of exciting. I love a good set of data and some Tableau that lets you manipulate that. So for us, that's really useful. And for community, that's useful so that they can really see what's happening in real time in their local area by geography, by zip code, and with other demographics in mind as well.
Ours is very similar in that we really we partner with Indian Health to make sure that we can effectively reach out to our Native American community. Again, with like a trusted community partner that could provide vaccines. We have a large immigrant population. Using schools is a very successful with some of our families that have fear of going to the doctor or anywhere that they feel like immigration could be an issue. And so, or that they have to fill out a form with information they're not comfortable with. So using our school sites for that population is really effective. We also made sure that primarily the location, that we were very strategic in picking which schools we would have the vaccinations so that we can make sure we're addressing students that would be less likely to go to, a primary care or to be able to feel comfortable walking into a pharmacy to get a vaccine. So we were pretty strategic in the locations of our vaccination events. And overall, it's really right now. I don't feel like our community is as inequitable in the vaccine distribution right now. Most of the pushback we get is from a very different community that doesn't want to get the vaccine, whereas I think we've been able to address some of the inequities in a very strategic way as a state.
I'd add a few other things that we're really focusing in Seattle and King County on a very multimodal approach, where school-located vaccination is a supplement to other systems and networks. We have community vaccination events that are located at faith-based organizations, that are at community centers, that are at Seattle Housing Authority, King County Housing Authority, other places where people gather and meet. And we are working with, as Sarah mentioned, many folks in our community mitigation recovery branch. We have a team of community navigators that speak a variety of languages, that are from a variety of different communities and are actively in community, not necessarily as public health or county officials, but as partners, and being there and understanding what the needs are so that we can be responsive to that. We have a universal approach, trying to make sure that as more people become eligible, we are making sure that access is available to everyone, but really dialing in and not going away. As a health department, we have a history of perpetuating racism, perpetuating a lot of inequities, because we go in, we do what we think we need to do, and then we leave. And in this response, I've been really proud of the work that our whole broad team has done, in that we're not leaving. We are here and we are supporting communities as they make their decisions, knowing that is not a binary thing. It's usually a process. And so school-located events are great. They are a supplement, and we are continuing to show up and be in community in many, many, many other ways, and frequently, even if that means an event vaccinates 3 people and not 300.
Great, thank you. Tiffany, anything you'd like to add?
I'd like to add that something that I said earlier, which is how important sustainability is. And so there have been experiences in these diverse communities where we've swooped in when we've had lots of grant funding and said, look at this great programming. And then when the funds run out, you leave. And so there's not a lot of discussion sometimes or thought that goes into actually making sure that you can sustain these programs, because as we know in public health, it takes a long time to influence behavior change and adoption. And so we have to, at the outset, start thinking about, okay, we've got tons of money now, but how are we going to keep this going? And so we're working with our partners to have a third-party billing solution where you can bill health insurance companies and get reimbursed. So there are a lot of folks now who say, oh, well, we have all this money, we can't bill now. Well, you can bill now so you can get some non-discretionary funding that you can, or discretionary funding that you can save for later, because this money will run out and I'm not sure that the problems will be solved. So we need to think about, how do we sustain this and how do we bake that into every part of the planning process so that folks won't blame us once again for showing up, saving the world, and then leaving.
And then leaving. Yeah, Tiffany, that's a great suggestion, and we are about out of time. But I would like, since sustainability is so important for having a lasting impact in public health, see if others would like to add to Tiffany's comment about how you're going to sustain this. So I get that you have a lot of funding now, which is helping with the COVID vaccines and hopefully with the related catch-up and flu vaccines too. But Tiffany's point about building infrastructure that can be there when there's not so much emergency funding available for vaccines in a pandemic, but that could, for example, connect you more effectively to the health plans, which are required to cover all of these shots. Other ideas that you all have about sustainability, and we just have a couple minutes. So maybe we'll go to Caitlin and Sarah next.
I think
Well,
the big
my
thing I would
regular-
mention- oh, sorry, Sarah.
No, it's okay.
I went first last time. You go first.
My regular work, if we weren't in a pandemic, is around supporting school-based health centers, and that effort is really important to me. And so we'll continue to have our school-based health centers be an epicenter of routine childhood immunizations and COVID vaccine, which is now, required by their fund, which is, their funder, which is our county and city, to make sure that vaccine is included in the vaccines that they're able to provide to students. So that's one strategy that we know can be sustainable and that we're grateful for to have in our community. And as we expand our school-based health centers across our state over the next couple of years, that would be part of routine care. So that's one sustainable strategy, and other things Caitlin can comment on.
I think the big thing I would want to point out is the relationships, is that there's not really been the opportunity to build these relationships. We've had health over here and education over here, and very few opportunities where those two pieces meet. And I think this has forced those two systems together in a way that is really building human connection that is a platform for further efforts. So whether that be school-based referrals to specific pediatric providers that can provide COVID and MMR and Tdap and HPV vaccination, we're doing that. It's the school-based health centers, but it's also relationships with our emergency medical providers, with our federal pharmacy programs. Once we know that we can do it, it's a lot easier to keep doing it. And hopefully there will be funding or funding mechanisms that will allow it to sustain further. But without the relationships, it's impossible. And so this has really offered an opportunity to build and sustain relationships, even as funding adjusts.
Mm-hmm.
Thanks. And Gabriella, I'm going to give you the last word on this as we wrap up.
I would definitely agree with what was just said, increasing our school-based health centers. And I think this has brought to light the importance of health. As in education, we look at Maslow's hierarchy of needs. And if we don't have that established, we quickly see what happens in the classroom. And so the increased need for us to be partners, and the increased need for us to utilize our school-based health centers and increase them, really, we've seen over the course of the pandemic, right in our face, how important it is to have successful in-person learning.
Yeah, we sure have seen that. And I really want to thank you all, not only for all your efforts on the ground to make sure we have successful in-person learning supported by effective school-based vaccination clinics, but also the time to contribute to this discussion. You all did it very efficiently. We do have a little bit of time now for a break. We're going to restart again at 1:45 Eastern time with our next panel. Look forward to seeing you all then.
I hope you enjoyed your break. And I think that first session set the bar pretty high for us. That was a wonderful session. But I am pleased to moderate this next session on how we can improve routine and seasonal childhood immunization rates in the context of the COVID-19 pandemic. As Dr. Levine and Dr. Vogt highlighted earlier, many children and adolescents across the US are behind on receiving life-saving vaccines. School-located vaccination efforts are one way to promote catch-up of routine and childhood vaccinations. Today, we'll be hearing from 3 experts who will provide a brief overview of the gaps that they are seeing in routine childhood immunization, specific challenges that schools and public health departments face in this area, and how they are working to address these challenges and improve immunization rates for school-aged children and adolescents. Please continue to submit your comments, resources, and questions in the Q&A function on Zoom. Okay, so I am pleased to introduce Ron Balahadia, Immunization Branch Chief for the Hawaii Department of Health, Eva Stone, Manager of District Health Services in Jefferson County, Kentucky, and Judith Schley, Associate Director of the Public Health Institute at Denver Health. And Ron is actually a former past chair of AIM, so I'm really excited that he will be sharing his experience with us. Thank you for all of us for joining. And I will start by asking the panelists to tell us a little bit about their experiences with school-located vaccination clinics. What are the key elements of your approach and what has been integral to your success? So let's start with Ron, who will provide us an overview of his work over the years to increase flu vaccination rates in schools in Hawaii. Ron?
Hi, Claire, can you hear me?
Yes.
Thank you so much. Really appreciate this opportunity. Hawaii has started actually with the school-located vaccination efforts with influenza vaccine. And we've been doing it for over 10 years annually and providing this opportunity to our children here in the state. We actually have been really lucky in how we've been able to formalize and put this effort together. A lot of it really is really important stakeholders throughout our community. So we've really benefited a lot in coordinating these efforts. And it's just been an exciting time, but at the same time, it's really very difficult because it takes a lot of work to get these things set up, planned appropriately, implemented, and then really just going through the process of doing lessons learned and how to improve for the next year. Overall, we've been lucky in that we partnered initially with our insurance companies that help support and subsidize this program for the state of Hawaii, in addition to federal funding that we've were able to secure under our grant, and then other small pockets of funding throughout the state. We start our planning actually early in January, and our vaccinations efforts start in the school setting in mid-October. This gives us an opportunity to plan appropriately, but also at the same time to anticipate any possible issues or problems. And so we've been fortunate enough to be able to handle majority of these school-located efforts through our actual program. We have not farmed out this particular program. It's an integral program within the Hawaii Department of Health Immunization branch. So a lot of effort, a lot of key components, but also more importantly, a lot of support. We have as our partner, our public health nurses that provide our clinic manager setup in each of the different school settings. Of course, the Department of Education is an integral partner with us, and also our private schools and our charter schools. In addition, we partner with a staffing agency that provides us with vaccination efforts throughout. So really a lot of work, a lot of effort throughout. And then also lastly, but definitely one of the more important parts of our school-located program are the parents and the children that participate in the program. This is a voluntary program, and even the schools are voluntary as far as them participating in the program. So it's a year-round effort, but an effort that I think we are really glad to have. Definitely a lot of challenges in COVID times. And so we're really trying to adapt and learn as best as we can in doing appropriate distancing and all the mitigation efforts that are needed to minimize any possible exposures. So this is actually a work in progress for us, at the same time learning and trying to share lessons, but also learning from others in what they do. So I'll stop there and then give others opportunity. And if there's any questions, I can circle back.
Thanks so much, Ron. And, you said that it was a lot of work, and I just want to give folks a visual of that. I was lucky enough to be in Hawaii several years ago. We were hosting a Pacific Island meeting, and I got to see Ron's office, and his entire hallway was lined with coolers and boxes to transport the vaccine and materials. And then they had a big opened a refrigerated section for the vaccine. When he said that, they were doing the vaccine clinics at schools, they were taking it on. And it was amazing how it was organized. Everything was organized by the school. And, we just had to walk down the hallway, and it was just evident that they take vaccination in schools seriously. So it is a lot of work, a lot of planning, a lot of collaboration. Let me turn to Eva and have you talk about your work with schools in Jefferson County, Kentucky.
Yeah, so vaccinations is always a big lift for school districts. We've done lots of work in partnership with our local health department and the Board of Health. The Board of Health actually has taken on immunization rates in the past couple of years as one of their objectives because it's become such an issue. When I started with the district, we started a health service advisory council so that we could get some stakeholders at the table to talk about pediatric groups and other stakeholders, advocacy folks, so we could look at immunization rates in the district. Expansion of school-based Medicaid billing, which was reversal of the Medicaid free care rule that CMS issued guidance on in December of 2014 has been a big deal for us. Our school nurses, our district, we've become providers for the Vaccines for Children program because of the ability to bill for those services. And so that's something that states will it depends on their state Medicaid plan. Kentucky had to do an amendment to the state Medicaid plan to allow for that expanded billing, but we think that's going to be an incredible opportunity for us to help address some of the gaps in immunization rates that we have in Jefferson County. And then with the pandemic, we've brought on nearly 100 additional school nurses. And so that will significantly help us address some of those issues as well. Next slide, please. So some gaps that we've noted in the routine immunizations when I started with the district, it was around the time Kentucky required that 2 doses of hepatitis A vaccines. We were one of the last states in the country to have that requirement. And when we started looking at those grades that were audited by the state, it became apparent that there were some significant gaps in immunization rates. So that really prompted us to do a deep dive into our data around immunizations to look at where there were gaps and where our students were not receiving immunizations. And that really showed us some disturbing trends. And that was that nearly 1 in 5 of our children in the district were missing current immunization certificates. And that was nearly 20,000 students. Of those students, almost 92% of those were children living in poverty, and 61.4% were children of color. And so when we talk about disparities and addressing disparities on whether it's my local school district or on a national level, I think it's important that we begin to be able to visualize immunization data and things in the context of the disparities that exist. There were lots of reasons that this was happening, and a lot of it had to do with the structures that the setup. We had low participation rate among providers in the city in the Vaccines for Children program. And some of that was because of reimbursement rates. Medicaid in Kentucky reimburses $3 for an injection. And so it was not cost effective for many providers to participate in the program. And then some of the predominant managed care organizations for those children living in poverty had very strict rules about children being only just able to see their primary care provider. And if that primary care provider didn't give immunizations, then they were told that they needed to go to the local health department for vaccinations. And at one point, our local health department in the city of 700,000 people had 1 nurse to administer vaccines. And so those are significant issues when it comes to ensuring that children have access to immunizations, which is likely a big part of the immunization gaps that we have. Next slide, please. And so we've had significant, and we'll continue to have some significant issues to support issues in addressing these catch-up efforts. And one is, as I mentioned, is reimbursement rates for vaccinations. We have become Vaccine for Children providers, so that sounds great. We've got basically 155 school nurses now, and they could be administering immunizations. But if any of you who are back to school with COVID know how labor intensive that work is, and the work of contact tracing, and our school nurses are very overwhelmed right now with that work, and that is doesn't lend itself to the situation where they can be administering immunizations. Historically, we've not had communication between state immunization registry and student data system. We're fortunate in Kentucky, we have one student data system across the whole state. And that data system didn't communicate or doesn't communicate with the state immunization registry. So we've fortunately, this has been a big effort we've undertaken throughout the pandemic. And so this past Tuesday evening, our school board passed a data sharing agreement with the state, the Kentucky Health Information Exchange, and we implemented an electronic health record in the district. And so we are now going to have communication between the immunization registry and our electronic health record. Fee-for-service models are challenging because it's not value-based, so there's not big incentive for providers who aren't giving immunizations. And then HIPAA and FERPA is a significant issue in school health in general. There's been lots of talk about school health and things that we can be doing in schools, but HIPAA and FERPA issues need to be addressed. Next slide, please. So some of our major work is to establish memorandums of agreement with our area pharmacies. Again, work with our school-based health centers. We have several school-based health centers. We are shifting our focus to what is the impact of having those school-based health centers, because we have centers in our schools. It's nice to have them there, but if we don't have our compliance in those schools should look better than other schools. And right now that's not what we're seeing in the district, and we'll continue to work to make that happen. And then we've established multiple memorandums of agreement with our area healthcare system and other partners who will also help with the immunization efforts that we are putting in place within JCPS.
Thank you so much, Eva. You've really hit on some of the top challenges, and congratulations on the progress you've made with data exchange and with the Medicaid and recognition as a Medicaid provider and the admin fee. That's incredible. So glad you were able to talk about that a little bit. Also encouraging folks, if you have comments to add on these challenges, please put them in the Q&A. And also we'll now hear from Judith. I'll turn to Judith to talk about an overview of Denver in their school immunization program.
Thank you. Can you go to the next slide, please? So first of all, I want to give a call out to Dr. Tara Vogt. This program started originally with two grants from the CDC that Tara was my project officer on, to actually implement school-located vaccinations and figure out a way to bill for services to make them sustainable. And so Tara, we made it sustainable. So that's a good thing to say. So first I'm going to describe our in-school immunization program. I'm going to highlight the past work we've done with Denver Public Schools, which is the main district in Denver County. And then I'm going to talk to you about planned activities we have for the 2021-2022 school year. Next slide, please. So this gives you an overview of what we've done. We've partnered with the in-school immunization program with Denver Public Schools for over 10 years. They worked with us initially on the grant, and then we have continued with them. Well, we go to schools that do not have school-based health centers. And so what we do is we provide both required and recommended vaccines at schools, irrespective of their insurance status. We do a consenting process where parents consent at the beginning of the year, or the school nurses actually determine that students' needs for compliance issues, certain vaccines, and then we offer all vaccines to them. And it's very nice. We carry private and public vaccine in there. We bring in, a team of people with all the vaccines, and then we do it either on a day, 2 days, or 3 days, whatever is needed. The school district, one other thing in terms of the parents and consenting, if parents, it's an opt-out process for consenting. so that if parents opt out of a certain vaccine, our staff will call the parents and ask them why and try and discuss the reasons why some of those vaccines are important. Required versus recommended, that always gets people confused. Well, if it's required, it must be better than the recommended, and we have to deal with that. We have in Denver, the school district has a very diverse population, and we focus on schools that have what we call low compliance rates and that don't have access to health centers or and need help. We do it during the day, and the parents consent prior to the clinics and do not have to be present to it. It only takes about 15 or 20 minutes for each of the students to be in and out of class, which really is much better than a non-compliant student having to leave usually for a half a day or usually even a full day. And we provide all the vaccines and services are billed, but no parent receives a bill for it, but we bill the insurances. Next slide, please. I just want to show a little bit of data. We do middle schools and elementary schools. This is data through 2019 from 2015. Before, when the middle schools, we used to go 3 times a year so we could complete the HPV series. That changed. And so you could see the number of patients, the number of vaccines we've done. We were going a lot to the similar schools or the same schools. And so there was a lot of people that were had already completed some of them, so we would just focus then on flu. But you can see for the elementary schools, we sort of, except in the last year, and a lot of it had to do, it's always an issue of how to get parents and schools to be engaged in this. And we started some new schools in 2018-19, and so there was a loss. And then 2020 was, we didn't get into schools. We got in there in the fall, but then in the spring, we didn't get there at all. Next slide. And then here you can see over the course since 2012, we've given over 26,000 vaccines cumulatively, which is really showing that we've done a very good job of getting in there. And these are, I could give a slide which shows all of them. A lot of it's flu. Adolescent vaccines are very high also. And then we catch up kids on the MMR in particular. Next slide. And then here, this is what school districts worry about because they have to report it to the state. And so this just gives you a snapshot of 1 year, 2018, 2019, where you can see the schools that we went to, the number of students and what the compliance rates were before we went into the schools. I'm not saying we were the only reason that the compliance improved, but we in middle schools were there twice because of course the HPV vaccine, we want to complete the series. So we really time it that way. And you can see an improvement in compliance, which the school district is very happy with, and then more minimal improvement in the elementary school. Now notice it's one thing to note is we give a lot of flu vaccination, and that is not part of their compliance assessment, but that is very important, I think, for mitigating flu spread. Next slide. So what we're planning for this year, we've already started, we just started this week. We're providing all the vaccines required and recommended in the schools, and we include COVID. What we did was we built last year was a DocuSign program in English and Spanish, and it includes all the vaccines, including COVID. So even for our 5 to 11-year-olds or 4 to 11-year-olds, when COVID vaccine is ready, we've got already consents done, and we can then get started. So we're starting with middle schools and moving into elementary, hopefully when we can do COVID too. We give the whole complement of vaccines, and then we have now offered it to parents too. They don't have to be there, but if they want to come, we'll give COVID and flu vaccination. And then I'm going to show in a minute, don't go to the next slide, why a theme of this, I'll show you some data of what's going on with MMR in Denver. And then lastly, we were sort of a separate group from the school-based health centers, which Denver Health runs. So now we have developed a more comprehensive program where we are doing it together with Denver Health School-Based Health Center to enhance it. And we focus on schools that don't have a school-based health center. Next slide. And then this is just a photograph of Denver. And what you can see here is this is MMR completion rates by neighborhood for 4 to 6 year olds, where the population estimates are the denominator. And you can see that no community in Denver, this is done in June of 2021, no community is at 95%, which is what we need for MMR. And you can see it's on average about 66% as a community. We're going to be going to the schools that are on telehealth pilot, which is part of the school-based health program, and so that we can complement that work where they're going to help school nurses with kids who are sick. Next slide. And I just have one more slide. So in terms of challenges and opportunities, there are a few things, and I think HIPAA and FERPA are definitely an issue, but cost of covering these approaches is hard. We can cover about 50% of our costs with revenue. We're using now COVID vaccination funding to cover all the staffing that's needed, but that's always been a concern in how to really do that. School staff is overwhelmed, and they've always been. A lot of the schools have had one nurse per week, which limits engagement. And so that's why we're teaming up with school-based health, so we can have more of a comprehensive package of services. And of course, we really know that we've identified risks in community for measles, and we want to use that data to identify the community needs and then prioritize those schools that we can then help improve that. And with that, I've just got my contact information on the last slide. So thank you very much.
Thank you so much, Judith. And thanks to our whole panel. Great to start us off with these presentations. I'm going to start with a question from the audience first. Can the panelists comment on the process for consent and administration of childhood vaccines in school clinics? Do parents have to be present? Is there an age cutoff to administer without parents present? So let me ask Ron to comment on this first.
Sure, thank you so much. So the consent process, we provided the consent forms, and we actually tried to go electronic, but we found that a lot of our really the children that needed the vaccinations the most, oftentimes their parents did not have access to some type of computer or electronic means to be able to sign up. And so we went ahead and just provided both options of handheld hard copy consent form and also an electronic means to register. We found that majority of the parents were very comfortable with having that consent form, filling it out and submitting it back to the schools. So that was our process of getting that completed. They signed off that their child, and again, this is just specifically for influenza vaccines, that their child would be able to provide or get that vaccine. Our program is from kinder to 8th grade. We tried going all the way up to 12th grade, but we found that the higher the grades we went, the less kids were wanting to participate. And so we wanted to focus on the younger kids. And then also, as far as parents, they can come and show up to the schools with their children, but majority of them don't. But they all know their children. And so some that are going to be a little bit more anxious or afraid, some of the parents do show up. We don't force children to get vaccinated, even though the parent signs the consent form. We will contact the parent if the child is hesitant and is crying and really is not at a good place. And our nurses usually pull them aside and then communicate with the parent and let them know that we're not going to be vaccinating them. But the parents are not obligated to be there. The consent form does allow for us to administer without their presence.
Great. Okay, great. Thanks, Ron. Yeah, I recall Tiffany telling me that it's easier to vaccinate kids if the parents are not there. But Eva, can you comment on your consent and whether you have parents present?
Sure. With our school-based clinics, it's the same. Parents do not have to be present, but they are certainly welcome to be present. When we did COVID vaccination clinics at most all of our middle and high schools. We did those in a variety of ways. Some of our vendors would not give vaccines without parents present. And so we tried to utilize more the vendors that would vaccinate kids without vendors present. So it just really depends on the provider. But we do not, internally, when we're administering vaccines, do not require parents to be present.
Thanks. And Judith, can you comment about how you do it in Denver?
Yes, so we did paper consents for a long time until this year's our DocuSign inaugural year. But we always had paper, and we still have some paper. I think with COVID, we tried to actually limit paper because it was a lot of pieces of paper that you have to give people, and it's costly to develop. And we do it in English and Spanish, and it's hard for people to store those things. And with whether parents come or not, as I said, parents don't have to be there. We enroll them at the beginning of the school year, or the school nurses will do it. And so then if they want to be there, they can. And we then have a nice team where we actually work with them. We provide like stickers and pencils and things like that to as an incentive for vaccination. And then we always give an aftercare information about the vaccines that we gave, so the parents know exactly what happened. And at the end of the school year, every parent gets a summary of what the kids got for the year, as well as the schools get to upload that information.
Nice, thank you. So this is a specific question for Eva, but I think it's a common one, so I'll ask it as from the Q&A. Is the school-based Medicaid billing that you mentioned part of the Medicaid in Schools program? How have either program been useful during the pandemic and getting children caught up on vaccination and wellness visits? I'm not familiar with the Medicaid in Schools program, so I don't know if you can comment on that.
I'm not familiar with it by that name, but every state has its own name for how they do Medicaid in schools. Prior to reversal of the Medicaid free care rule, school districts could only bill Medicaid for services that were in a child's IEP. And then in December of 2014, that CMS reversed that ruling, that limitation that had been placed there. And so most of the states at that time had to request a state plan amendment. So there had to be, for example, in Kentucky, we had to approach Medicaid, and really there was some advocacy group work with Medicaid to request that state plan amendment that would allow for this expanded billing. So every state sets up that billing. It might look a little different, but basically it allows for billing of things outside of an IEP. And so in Kentucky, it's for any service that's medically necessary. So that includes nursing, but that can include a lot of other services. So that's what allowed us to enroll as Vaccines for Children providers. And really our goal in Kentucky, in Jefferson County, is to connect every school with an entity that can give vaccinations, whether it's a pharmacy, whether it's a school-based clinic. And then we can use our nursing staff to really focus on, we've got about 12,000 students that are enrolled in English as a second language. We have encountered some barriers to our families, particularly those immigrants and refugees in the past several years have been reluctant to sign up for Medicaid, even though they're eligible, because they've been afraid of the consequences of that. And so what we want to do is focus our nurses on providing immunizations for those children that don't have a provider. And so that's what our goal is in utilizing this program related to vaccines.
Thank you. Do either Ron or Judith want to comment on Medicaid and any role of Medicaid?
We bill Medicaid for the administration fee. We use VFC vaccine and then bill for administration fee. And so that's how we do it. And then we bill all private insurances too.
For Hawaii, sorry, for Hawaii,
Go ahead.
we've actually been lucky in that we have not engaged in with Medicaid. It's something that we definitely have had on our on the table for discussion, but we've had our insurances and other entities that have supported the program. So we've been looking in that regards, but definitely Medicaid has been a partner of ours, but also at the same time looking at trying to see the mechanisms. As I mentioned earlier, the state program runs this whole operation, so it's a lot of work to try to delve into other areas, but definitely would be willing to learn from others on how best to utilize Medicaid.
And if I could say just one more thing about it. So there's been a lot of talk in this meeting about sustainability. And so one of the barriers to billing Medicaid outside of a school-based health center, because school-based health centers are set up with their own rules. If you're talking about billing within school-based Medicaid, you cannot bill for anything that is federally funded. So for example, in our district, we brought on about 100 school nurses through using ESSER funds, and we're not able to bill for those services because they are federally funded positions. We can only bill for those positions that aren't federally funded. So from a sustainability perspective, I would just pitch out there that I hope this is something that the federal administrations will look at and look at perhaps giving school districts the opportunity to be flexible with those billing practices while we're trying to get through the pandemic and build some sustainable systems to help recoup what we know is going to be a huge problem. Our data from Jefferson County shows that at the end of last school year, less than 40% of our kindergartners had their preventive health exam, and 9.9% of our sixth graders had a preventive health exam. And so we know what's getting ready to come with immunizations. These kids are missing, have not accessed the healthcare system, and we need schools and communities need all the support that we can get to get resources to our children where they're desperately needed.
Thanks for pointing out that distinction between the federal support and what you can bill Medicaid for. I just wanted to comment a little bit further on that. So I think that Ron's program is a school located vaccination clinic that's not actually happening in school-based centers. So, the public health department is really taking on a lot of that. And in order for them to bill, they have to be recognized as providers, both for the private insurers and in Medicaid. And that's for an admin fee, right? If the public health, or in this case, with COVID, the federal government is providing the vaccine, you're obviously not billing for the vaccine, only for the administration fee. And then in the school-based centers, they have those children, I guess it's Medicaid, enrolled as, patients or whatever, so they can bill for more services. There are no shortage of challenges in all of these. I just wanted to sort of point out some of those distinctions. Okay, well, let's move on to the next question. And this is a question from the Q&A for Judith about your program in Denver. And if you could expand on, and we'll also ask Eva and Ron to join in this one. I think this is a common one. Can you expand on the FERPA and HIPAA challenges that you alluded to?
Sure. So we go in with our electronic health record. I run the immunization program at our health department, and we go in with our electronic health record. We do not have access to the Infinite Campus records for the school district to see what's up to date for a child. We want to know what they've had, because our IIS system might have some things and it might not have everything that has been put into the school records. So we actually had to pay for a paraprofessional to actually be that liaison. We pay for it. That person is employed by the school district, and then they can look at things, and then we can then deal with it. We tried years ago to try and address that with the H1N1. There was a hope that maybe then there would be changes with FERPA, but that did not happen. And that is a true barrier because we're trying to know individual health information for all sorts of things, just their school vaccinations, so we can give them, we don't over vaccinate, and then we don't miss opportunities. So It is a real challenge, and it's costly because we have to pay for somebody to help us.
Thank you. And Eva, do you want to comment on how you were able to make the connections in Kentucky?
Yeah, to say a couple things. So the immunization records, we're able as school nurses to access the state immunization registry one person at a time, because HIPAA allows provider to provider sharing of those records. FERPA, which schools are under, is a records law. And so FERPA does not allow for immunization records to be shared with another entity, because there's no provisions within FERPA to allow that. So unless I get a specific consent form signed by every single parent in the district, I can't take the records that I have in Infinite Campus, which we also have Infinite Campus in Kentucky, and reconcile those with records in the state immunization registry, because my records are under FERPA and I couldn't prior to this week share them with the registry. So what we've done is we've worked with our state health information exchange. We've created a data sharing agreement that allows us now, that our board enacted, that allows us to share those records. So the state really has set this up in two ways. In Jefferson County, we are specifically having records. We'll be drawing down records from the state immunization registry. So they'll come directly to our district, because HIPAA will allow those records to come to us. In our case, they're going to go to our electronic health record, but other districts in the state who choose to use this data sharing agreement will be able to draw that down their records to Infinite Campus. For us to give records to the registry, we are going to have to do that child by child, but we set up the data sharing agreement so that when the parent signs consent for us to administer the vaccine, then we can upload those vaccination records automatically to the record without somebody have to manually do that data sharing.
Thank you. That's really helpful. And I don't know if you would consider sharing that consent form that you use. I think that would be helpful. These are great to hear, these solutions. So I'm gonna go to some of the questions that we had down for you, because they're really good, and ask you to talk about your have you combined COVID vaccination clinics with other catch-up efforts or flu clinics? Why or why not? And I know, Judith, you talked a little bit about this, but would love to hear more detail on this. I found this fascinating from the last panel. And also, what you are thinking about for 5 to 11-year-olds, please share that as well. Let me go to you, Ron, to kick us off.
Thank you. We actually have not combined efforts at this time. We are planning on trying to do that. It's just one of those things where there's just so many, sadly, competing priorities as we move along and address a lot of issues. But as far as the trying to do co-administration of influenza and COVID, that is something that we are in the works. We have done already COVID vaccinations for our middle school and high school students, and we coordinated efforts with those providers, as was mentioned by Eva previously, that want to participate in the program and actually have the Pfizer vaccine, and then the school districts that want to participate, and then make sure that they have established dates of vaccinations. At the time when we did that, that was prior to the summer break. Influenza vaccine was not available at that time, so COVID was the only one that we were administering. As the flu season and influenza vaccines are available and are circling back and trying to get COVID vaccine out to the younger age population, that's definitely something that we're trying to coordinate. Logistically, it's just another added piece that we would need to make sure we coordinate appropriately with our providers to be able to do that. But it's something that we're definitely trying to engage in and see how best to provide that. Over.
Yes, I mean, I think like logistically, it's more than just another thing, right? Just because of the Pfizer vaccine being so different, the way that it's handled and mixed. So, we'll see what comes with 5 to 11-year-olds. Maybe it will be simpler and the packaging will be simpler, but certainly, yes, it's a challenge logistically too. So Eva, let me turn to you and ask you to comment on what you're planning or doing with COVID and potentially co-administration.
So we haven't done the clinics yet, but that has been our intention. That's what we've been planning for. So the big first step was the data sharing agreement, and then the ability to get those records and have current immunization records for kids. We've worked with getting our memorandums of agreement in place. So for example, we've got one large pharmacy chain that we've worked with, and we've asked them to add childhood immunizations to that memorandum of agreement so they could be included. And then we've entered into memorandums of agreement with some of our large healthcare system with the intention of having them administer all vaccines, not just COVID vaccine. And we've made that ask for anybody who wants to partner with us, that's a requirement for a memorandum of agreement to be giving vaccines in the school. And then finally, we're redoing our MOAs with the school-based health centers that we have that would allow them to send staff to some of our other buildings to also work on providing immunizations for children.
Great. And I'm assuming that they would be responsible for transporting for everything from A to Z for the vaccine.
Yes, actually, that they give. And our state has been incredibly helpful in working with us. They're well aware of the issues and challenges we've had and been very supportive in helping to address these things.
Great, thank you. Judith.
So in our consenting process, we list all the vaccines, and now this year COVID too. So when a parent does the consenting, they consent for everything. And then when we go into the schools, we will provide any vaccine they need. And if they need COVID vaccine, we'll give them COVID vaccine or flu or whatever. And we're trying to start with the middle schools first, because we can do the 12 and up right now with COVID vaccination. And then when we can go, and then we'll move into elementary schools where hopefully at that time we can do COVID vaccination as well as others. We've been doing outreaches and for all sorts of people and food banks and homeless shelters and that. And now we're doing flu and COVID as we go. And at times we've brought Hep A because we worry about Hep A and things like that in the homeless population. So we're very comfortable giving multiple vaccines. I think initially our work was really about getting COVID vaccine out into community, and we mapped out a lot of places where COVID vaccinations were low, and we prioritized those communities. And so our teams were really good at one vaccine. So we had to train them to do multiple vaccines, and that took some time. But they're very comfortable and they can do all the vaccines. And it's hard when you have a kid that needs 9 vaccines. Let's just say that's a big challenge. That takes more than 15 minutes.
Yes. And training all of the, training your providers on that, having that 15-minute observation period, there's just so much all around. Well, let's talk about your key stakeholders. How have you worked collaboratively with other key stakeholders? So that would include on the public health side, on the education side, the leaders, even your pediatricians. Are you getting any pushback from your physician community, from your PTA, everything from A to Z? Let's hear how you're getting that done. This time, I'll start with you, Eva, give you the floor.
Sure. Well, a couple of things we did. First was to establish just a health advisory council with many of the healthcare groups, pediatric groups, getting all those people at the table. When you present the data, particularly some of the data we have, it's pretty hard to argue that the system's not broken in some ways. When 92% of your children who are showing as out of compliance for vaccinations are kids living in poverty, there's a significant health disparity, and 60% of those are children of color. So getting all those folks together just to be open and honest about the data and then talk about the system. And so in Louisville, our public health department really picked up and has been an incredible partner. And the Board of Health even formed a task force. One of our nurse practitioners who's been very passionate, done a lot of work. In fact, she did all the lifting to make sure that we became VFC providers. Is because of that partnership. And then of course we've had our state support, and then our community health centers and FQHCs, they've all been at the table, and we've just talked about how do we address this as a community. As one of our pediatricians said, you know, this isn't Jefferson County Public Schools problem. This is Louisville's problem. The healthcare system has created this problem. Now, how do we all work together to fix it? And her words are very wise, because all those children are our responsibility collectively. So I feel we've got a very strong partnership in Louisville to help do that.
Judith?
And well, we have a strong relationship with Denver Public Schools. We've had that for many years. It actually is now enhanced because we're teaming up with the school-based health to be a complement to that work, so we can have broader reach to reach more students, and then support them in getting comprehensive care through school-based as well as in through vaccinations with us. They're actually piloting a telehealth program in the schools that we're at, some that we're at and some that we're not, where they can support the school nurses with health related issues, like a kid who's sick and can they stay at school and things like that. So that's a big partnership, as well as with the Denver Health Medical System. We are very much involved in working together to enhance the areas that we want to, where we get communication out that we're going to be doing this work into community. The school district is sending notifications, texts, to push out the importance of vaccinations this year in particular, which has been really helpful for flu and COVID vaccination, which then helps us to go into the schools and the parents are more excited about it.
Thank you. Thank you, Judith. And Ron, do you?
Yeah, definitely within our public health system, we have our immunization program, but our big partners within our program are definitely our public health nurses. They take a huge load for us to be able to perform this program. As you're all well aware, Hawaii's multiple islands, so we have district health offices in each of the different islands that support this effort and are great partners to us. And then also our preparedness program to make sure that they're also involved in the logistics planning, et cetera, on how to ensure that this program operates. We definitely are partners with all of our school systems, not only the Department of Education, the public schools, but also our private and charter schools here in the state. So we definitely have school liaisons with us in this program. Another huge partner is our insurance groups that support and provide monetary money for us to be able to operationalize this effort. Pediatricians, not as much, but they are definitely looped in and informed about the process so that they know the kids that are being vaccinated in the program. And so we provide that information to them, working with our staffing agencies to provide additional vaccinators to help us in the efforts. Volunteers are also a huge part of this process, and parents that are participating and supporting of this effort.
Very, very helpful. And I think in this environment, these suggestions are so good about involving the broader community, having an advisory council, using your parents, involving your parents, using data, kind of just taking the politics out of it. And I think that's very sage advice. just you all are making it sound really simple, and I know that it's not. So I'm just giving you a heads up that I'm going to ask you before we adjourn. I'm going to ask you if you have advice for other programs that may be just starting or just wanting to do this, about you know, how to go about this and get to where you are. But there is a question in the chat box that I think is really good. So I'm going to go there now, give you a chance to think about perhaps what might be our last question. This is for Eva, but of course, love to hear from Ron and Judith as well. You mentioned creating an MOU with pharmacies to deliver the routine vaccinations. Are the pharmacies VFC providers? And if not, how is that financed? And how do you coordinate with your VFC as affected you are a VFC provider?
So I will say a couple of things. First of all, before COVID, the pharmacies really weren't interested in partnerships that would involve all childhood vaccines. But there is a way to make it lucrative for pharmacies because they make their money from flu vaccines. So if you can tie your clinics to also administering flu vaccine, then that makes it a little more financially interesting to pharmacies. So that is the first thing I would say. And then COVID is really what made the difference. So in Kentucky in an effort, and this was, you know, before I became very involved in this, but Kentucky allows non-VFC providers to bill Medicaid for kids with Medicaid now, but the reimbursement rate at $3 an injection is not very interesting to most providers. And so that is why I think tying it to something like flu clinics that makes it valuable to them is much more interesting and much more sustainable. So it's not that now what we will do, and what our initial model was before COVID, was that we would have our staff. We don't ever want to have a clinic and just either be giving vaccines to children with VFC and then private insurance being another group of kids that aren't offered immunizations. We want to be equal. And so our original model was going to be that our nurses, the VFC providers, would give immunizations to kids that had Medicaid within the schools, and then we would use the pharmacies to administer vaccines to kids without Medicaid. But now we have some other options, and so that should not be a barrier for us in Kentucky outside of the reimbursement rate. That's the barrier. If you pay people, they will do it. The issue is them not losing money, which is what a lot of our local providers say. I lose money to participate in this program. And so that's a policy problem that needs to be addressed.
Yes. And I think, you know, working around, it's very difficult to get pharmacies in the VFC program for a number of reasons. So, you know, working around that is, is certainly a good solution.
And the other challenge was the state immunization registry. Sorry, but COVID changed that. Because COVID, for them to administer COVID vaccine at a pretty decent reimbursement rate, connected them with the registry. So how do we keep that momentum going to change the model?
Yes, I love that. I do love that. One of the benefits of COVID, making these connections with provider data flowing. Judith or Ron, do you want to comment on working with your vaccinators, and are they VFC providers?
I can go unless you want to, Ron, but I can start. So we use our staff to do this, and we have upped our staff because we're doing all sorts of other things, and we've really enhanced all our outreach efforts. And so we are a VFC provider. Our pharmacies are a little different in terms of there's also a concern, not just, I'm not sure whether our pharmacies in Colorado are all VFC providers. I think they are, but you have to apply and you have to follow through all the federal requirements related to it. But the big thing is young kids and vaccinations by pharmacies. That's not something that pediatric providers have been so keen about. And so that has been a bit of a challenge. And I always think about it as the immunization neighborhood and what we're trying to do, which was talked about in the last section of how we have multimodal approaches to it. And so pharmacies can be one place, but they're not going to come into our schools. And, you know, working with students and little kids in particular, who they don't usually vaccinate in the pharmacies, is a different thing. And so I think we have to be thoughtful about that process. So we use our staff, we train people very carefully about how to work with young kids, because you got a 4-year-old or a 6-year-old, it's very different than a 17-year-old.
Yes.
And so, but we could do it. It's just the pharmacies have never been interested in it. And so, but they can give vaccines in the pharmacies, but they, I think, don't go down to the younger ages, which we want to catch up, especially the 4 to 6-year-olds. We're really hoping that we can get our MMR rates up.
Right. They actually, they technically can during this public health emergency vaccinate younger kids, but you know, that's not a sustainable model, and there's always the BFC challenge. Ron, let me hear your words of wisdom.
So for Hawaii, we don't have pharmacies that are in the VFC program, as was mentioned by Eva and Judith. Just the difficulties of reimbursement, and is it lucrative enough for them to be able to provide it. But with COVID, they definitely are vaccinating, and they will vaccinate down to the allowable age via through the PrEP Act down to 3 years of age. They're not comfortable. A lot of them have stated to us, but at the same time, they have that ability to go down to that age. For the state of Hawaii, our statute actually allows pharmacies to vaccinate 11 and up right now, but the PrEP Act actually allows them to go lower than that. It really is, as Judith mentioned, ability to do it on a regular basis and comfortableness, and just ability to vaccinate at that, because it's very different a 4 to 6-year-old than a 17-year-old. But at the same token, I think our pharmacies are being engaged right now. They do provide influenza vaccines to schools that either don't participate and or are having older kids that want to participate in the program, so they go out and vaccinate in those efforts. So I think COVID has changed the landscape a little bit for them, and which is great to hear. And we are trying to get them involved in the VSC program, but with those barriers, as mentioned earlier, it's a little bit more difficult, and hopefully we can get those barriers down.
I hear you. I hear you. Well, I want to thank all of our panelists. This has been a great discussion, and we're not going to have time to hear your words of advice. So if you want to put them in the Q&A, if you have any sage advice for anyone who might be starting out, that would be great, or we can follow up with you afterwards. But thank you so much for sharing your experiences. It's been wonderful. And I'm now going to turn it over to LJ Tan for our final session.
Thank you, Claire, and thanks to everybody for being on this great symposium, and thanks to Duke and AIM, obviously, for bringing me and giving me the opportunity to moderate this next presentation, this next panel discussion. And I think we've heard a lot of great discussion about how we can create infrastructure and try to put policies in place to facilitate a school-located immunizations. But I think the big question for today is obviously, if you build it, will they come? And so we need to think about here in today's panel, strategies for communicating with parents and building vaccine confidence so that indeed they will come. So good afternoon again, everybody. I'm LJ Tan. I'm the Chief Strategy Officer at the Immunization Action Coalition, and I'm delighted to be moderating this discussion today. And of course, introducing these wonderful speakers who will share a bit about their experiences with how they engage adolescents and the families to build vaccine confidence, as well as current research that's going on with vaccine attitudes and beliefs. I think one thing that we've heard very clearly from school officials and from public health advocates and leaders is that when it comes to school-located vaccinations, whether we're talking about COVID or whether we're talking about an annual flu clinic, is that getting it built, holding the clinic is only half the battle. And in fact, the hardest part in some cases may be getting the word out to parents and to communities that this clinic is now available, and then making the case for why they need to come and take that next step and get vaccinated. And throughout today's symposium, we've heard about that uphill battle that we've all faced in combating misinformation and highly charged political environments. But we can't forget that parents, as well as students, do have and will continue to have legitimate questions about the safety and efficacy of vaccines. And it is it is incumbent on us to address those. And this is the reason why school officials, school nurses, pediatricians, and other trusted community leaders are actually very important for connecting parents and adolescents to sound evidence-based information. So as we'll hear about, it's also important to empower students themselves to tell their stories and to connect with their peers about why they chose to get vaccinated. So today, we're going to hear from several leaders who are doing very important work to build vaccine confidence within their communities. And these are our panelists, as you can see on the slide. We are joined by Judy Klein, who is the president and founder for the Unity Consortium, Dr. Kathleen Ryan, who's the Associate Division Chief for Pediatric Infectious Diseases at the University of Florida Health, and Timothy Benally, who's the founder of the Indigenous Peoples Student Association at Penn State University. So I'm deeply grateful, and we are deeply grateful for their willingness to come on today and share a bit about their experiences. So I'm going to start by asking our panelists to tell us a bit about their experiences communicating with parents and building vaccine confidence. So specifically, I'm going to ask questions and ask them to address questions such as, what are the key elements for their approach, and what has been integral to the success of their approach? So we're going to start with Judy Klein. Judy, welcome. Thanks again. Who will provide us an overview of some of the recent research that Unity has done on adolescent vaccine attitudes and messages that resonate with parents and with adolescents. So take it away, Judy.
Thank you, LJ. And I echo it's a great honor to be here. And we couldn't have a subject that is more relevant and, an area that we can all of us lend our support to, which is keeping our schools and our adolescents and children as safe as possible from all vaccine preventable diseases, of course, including COVID. As LJ just mentioned, I wanted to begin by sharing some voices of our teens and our parents across the pandemic. But first, let me just step back for a minute and explain who Unity is, because as LJ mentioned, it takes all of us to get the messages out to our constituents. You are trusted voices within your communities. So if you could just forward the slides. Unity is an organization that is made up of a whole variety of different perspectives, all who are interested in the health of adolescents and young adults. Our specific goal is to ensure as many adolescents and young adults are fully vaccinated against all vaccine preventable diseases. And we do that through action-oriented leadership, innovation, education, and all of this to benefit our adolescents and young adults. Next slide. As I mentioned, we are a diverse group. And, one of the things I know we're going to hit later is what kind of partnerships will help you to get those so important messages to build confidence around vaccination in your community. And I feel like that is embodied in our membership and our liaisons. And we are made up of organizations from the public sector, including CDC, HHS, the private sector, including pharmacies, including vaccine manufacturers, professional associations, advocacy groups like LJ in the Immunization Action Coalition, different communities. We have, the Hispanic community represented both from a professional medical perspective as well as from a Univision, a communications perspective. That's just a sample of the kinds of partnerships I believe it takes to make sure you're getting to everybody in your community. Next slide. So as LJ just mentioned, we have been doing a multi-wave survey throughout the pandemic with parents and teens. It covered three major areas. One, just how they're doing, what are their stress levels? Are they taking care of themselves from a preventative care perspective? What has been their beliefs and behaviors around routine immunization? and then finally focusing in on COVID-19 vaccination. Next slide. The survey was completed online through a third-party market research agency. The first wave started last summer in August, September of 2020. The second wave was February, just before the COVID-19 vaccine was approved for 16 and over. And the third wave was just this past June, which seems like not too long ago, but as you all know, so much has happened in just the last couple of months. As I mentioned, this reflects the voices of parents of teens 13 to 18 and teens themselves of that same age. And we did have a variety of demographics representative of race, ethnicity, location folks live, and more. And I'll talk a little bit about that, but I only have 10 minutes. So should you have questions, please do put them in the chat and we'll try to get to them later. Stepping back onto that routine, preventative health care, which is, starts with the well visits. Many of our parents and teens, canceled or delayed that well visit appointment to the degree of almost 50%. The parents indicated had to do that throughout the pandemic. More so with urban parents, almost 2/3 of them said yes, they did delay the well visits. We've seen, some of that being picked up. As you can see here, in June, 93% said they were able to reschedule, but I know we still have a way to go to completely make up for lost well visits. Next slide. So, why did they feel like they couldn't go to well visits? And this kind of applies to other locations that folks would need to show up for vaccinations, for example. And if you look at the bottom, and this is wave 3, which is again in June, versus wave 2, which was February. The two most important reasons they weren't going was well visits were not urgent for them right now. And then second, and most importantly, they still had concerns about getting COVID at the doctor's office or clinics. And again, the pink shows that it did decrease a bit, but it's still, almost 1/3 of people. And by the way, we talk to our mom advisors and our teen advisors routinely. I personally thought that safety concern about healthcare provider locations was going down, but they said, no, that is really still important to them to hear that message directly from their healthcare providers and their public health community. Next slide. How about routine vaccines? And we asked them all across the board about routine flu, obviously, which is routine, and COVID-19. They believe throughout the waves, and this reflects all 3 waves, in the importance of vaccination, with flu and COVID being down a bit relative to the routinely recommended vaccines. COVID, as you could see, took an uptick in June of this past wave. Next slide. However, at the same time, we've continued to ask them about their vaccine safety concerns, and we've only seen those concerns being trending up. We actually did the same question, many of these same questions back in 2016, pre-pandemic. So we show the parents and teens responses for these 2 questions on the slide as well as wave 1 and wave 2. And if you forward one more, we'll get wave 3 on there as well. Thank you. So we asked parents and teens their agreement with 2 sentences. One, I have some concerns about the safety of vaccine, which you'll see the responses on the left, with parents' concerns going up to about 63%, so almost 2/3 having some safety concerns about all vaccines by wave 3, and teens, that trend is similarly reflected in their responses. On the right, the statement of what I've read on social media has me concerned about the safety of vaccine. That has gone way up from about 45%, so less than half back in 2016, to about 61% of parents and 57% of teens. So that is a significant increase just really over the pandemic, but also looking back to 2016. So though they believe in the importance of vaccines, they do have these safety concerns in the back of their mind. So we have to stay vigilant in our communication of positive messaging that will support them to be confident in the safety of vaccines. Next slide. In terms of thinking about the COVID-19 vaccine, and just you could keep going for a moment. Thank you. About 60% of the participants, the parents as well as the teens, did get their COVID-19 vaccine by June. And as you could see on the right, many of them were going to pharmacy. I know we just had a discussion about pharmacy, as well as their healthcare provider, their physician provider, I should say. Next slide. And again, still thinking about that COVID-19 vaccination and where parents are looking to get their information. You could advance this one more, I believe. Thank you. So this is just parents. It goes, the first couple columns is the source that they go to for information. And the second column is which source matters most to them in their decision to vaccinate. And you could see, and this has been validated in many other studies, that their doctor or other healthcare provider is their number one source and the one that matters the most. But as you can see, by wave 3, they were certainly broadening their sources, and the circled red area indicates other sources that they have been often going to, including public health, the internet, as we know with the social media, vaccine manufacturers, and their pharmacists. Next slide. And oops, sorry. Let me just mention the one which we already talked about, social media, though they say remains lower on the list of sources and doesn't matter as much, but yet on the previous side, they do say, however, what they do see does kind of niggle at them. So as we know that social media is a major source of dis and misinformation. Next slide. So what is motivating parents and teens to get the COVID-19 vaccine? With the blue parents on the left and the green teens on the right, across the waves, we see they want to protect either themselves or their teen, and they want to protect their family. In particular, when we talk to the teens, we know that they're particularly worried about the loved older individuals in their lives, like grandparents and others who they're close to. And that often is a reason for the teen to get vaccinated if they're hesitant or they're not feeling the urgency for themselves. Next slide. And what reasons do they not want to get vaccinated? As you all know, concern about side effects is the top reason, way above many of the others. But also back in June, as well as the previous waves, they, they're not only concerned, but one of the safety particular issues is that they could get COVID-19 from vaccination, which of course we see reflected in some of the flu safety concerns. Next. And then on the bottom there, but in rising importance, especially if you look across the waves, for example, that low one, the lowest one, I think my teen could get seriously ill. My teen will not be seriously ill from COVID-19. Has through the pandemic been, a reason for teens not to get vaccinated. As we know, the Delta variant has changed that quite a bit in reality. So we at Unity have tried to integrate that message of, yes, the teen is at risk for getting, symptoms associated with COVID, much more likely with the Delta variant than in the past. So, the fact that they think this and that, continue to go up is a good reason to get that message out, in your list of messages. Next slide. So looking at the parents who have not gotten their teen vaccinated, and that was about a bit over 200 of our participant parents. Parents' views on their teen, and this is just wave 3, about a third of them did not plan to get their teen vaccinated against COVID-19 at all. Next slide, because I wanted to show here how this varies by race and ethnicity. And in particular, and you could go click 2 more if you wouldn't mind. Thank you. So for African-American or Black parents, they intend to hold back more so than white parents when we ask that question about their intention to get their teen vaccinated. And you could see they're reflected in the pink bar. Significantly more said they would get the vaccine themselves and then decide if it's okay for the teen, or only get the teen vaccinated once it's required for school. Next slide shows for the Hispanic population. Again, if you could tick through 2 more times, thank you. And they also had a wait and see attitude more so than the non-Hispanic. So the Hispanic are in green, non-Hispanic in blue. And you could see that they were much less likely to say, more likely to say, I'll get my teen vaccinated when I can fit it in. They're busy, perhaps working, and it's more difficult to get access to vaccination. And then also similarly get the vaccine themselves and then determine if they want to get it for their teen. Next slide shows rural versus suburban versus urban. Thank you for that. And here, take a look at the bottom. Almost half of the parents residing in rural areas versus urban and suburban said that they do not intend to vaccinate. So that was clearly the most significant difference. Again, rural parents saying half of those who have not gotten vaccinated, we do not intend to vaccinate our teen. Next slide. We did ask them this time around in June about co-administration. And we do know that that's, by the way, a big message that still needs to get out, because folks are not aware that they can get their routine vaccines at the same time as COVID-19 vaccination. 70% said that's fine with them. 30% said, I have some issues. Of the folks who didn't say, I already am up to date for my teen, the biggest concern was safety of getting COVID-19 at the same time as other vaccines. Next slide. So just to wrap up the survey findings, adolescents and parents continue to recognize the importance of vaccines, but at the same time, concerns about safety are on the rise, ongoing impact of social media. And adolescents and parents are seeking information from trusted sources, including their healthcare provider. And finally, co-administration is mostly acceptable, though I want to also mention that many of them are not aware of the CDC guidance on that particular point. Thank you, LJ.
Oh, thank you, Judy, for that presentation. And I think what we'll do is we're just going to go through all our presenters so that they all have enough time. And then at the end, with our remaining 15 minutes or so, we will go ahead and have the questions come out and then address them to our panelists. And folks on the symposium, please make sure you put your questions into that question and answer box, and we'll be certain to get those questions out to people. Thank you very much. Okay, moving along, I'm delighted to welcome Kathleen, and you are here to talk about your work with schools in the Alachua County in Florida for promoting flu vaccines. I think this was something that, in fact, you all received a Summit Award for. So based on that, what lessons have you learned about the communications and the role of pediatricians, for example, in building vaccine confidence? So take it away, Kathleen, and thank you for being on.
Thank you very much for having me today. Next slide. So I'm going to talk about our control flu program, and this segues well with the presentations that came before this, but also talk about how we've communicated with the community, our parents, and the schools about the program. So the Alachua County program has been in existence since 2009-10 season, after a pilot year where we learned a lot about how to create the program, communicate with our community. about the program. Next slide, please. So this program is definitely a collaborative effort. As you've heard before, it's very, very important for this to be a collaboration between different entities. So we have the Alachua County schools, the public schools and the private schools, and the Alachua County Health Department. And for us, because we have the University of Florida, we have partnered with the College of Nursing and the Department of Pediatrics. That's where I come in, and the Emerging Pathogens Institute at UF. And each one of these entities is actually crucial to the functioning of the program, and each one provides important avenues for communication with different segments of the community, both parents and schools and the university combined. The next one. So our program has traditionally provided LAIV or flu mist free of charge, as you've heard from other programs, where we will bill insurance if they have it. We provide VFC vaccine, and if the child has no insurance, then they just get the vaccine at no cost. This comes at no cost to the parents. They will never get a bill. It goes to all Head Start, pre-K through 12th graders in the schools. The public schools can opt in, can have to opt in. The private schools can opt in if they choose so. And we can encourage students that can't get the LAIV in school to get their IIV in their medical home. And based on the modeling studies that have been done, our goal has been to immunize overall 70% of the students in the community in order to get to that herd immunity level. So the program starts in August. Our schools in Florida start early in August. And we have consent forms that go out in paper form, and we do an electronic consent form. And we have many back to school and community events before we start our immunization clinics in October and November. And these back to school and community events involve going to the schools for back to school night, parent teacher night, going to community events around the community. We have a lot of events here at UF around football, and being there tabling and communicating with our parents, and also especially to the teens. You'd be surprised how many of them actually go to their parents and say, I want to get my flu vaccine, after you've talked to them at one of these community events. Next slide, please. So we have over 27 community partner organizations and many volunteers. We've created this over the years. The community partners involve, like I said, the University of Florida, the Children's Miracle Network, AvMed, many community churches and volunteer organizations. And one of the most important aspects of the program is that the pediatricians in this community in particular are strongly supportive of the program. They're strongly pro-vaccine, and our whole message is get vaccinated, whether it's here in our offices or at school, but our most important message is that we all need to be vaccinated. And that has carried from the flu vaccine to our other programs, and also down to the COVID vaccine. And over the years, we've surveyed parents, and they like the program because it's convenient, at no cost, and parents that can participate once will participate again. Go ahead, next slide. So the nursing students at the University of Florida provide vaccine. This is part of their community health education. And we have many student UF volunteers and our medical reserve corps. Next slide, please. So this is what we've done over the years. We did go into the schools last year our students were in person school or had a virtual option, and we did provide LAIV. Our immunization rates were lower than they had been, and especially in the middle and high schools, but we were still able to get a fairly good percentage of the students immunized that way in the schools. Next slide. So we use that same infrastructure and that same level of communication to develop a high school vaccination program where we do catch-up vaccination for HPV, MenB, MCV4, Hep A, and Tdap. And we offer that to 11th and 12th graders. And we do that after our flu program in 2 clinics 1 month apart. Next slide, please. So even though our vaccination numbers haven't been particularly high, we did this in 2018 and 19. We did not do it last year because of the COVID-19 pandemic and the chaos around that. We feel like it's an opportunity for a percentage of the students to get their catch-up vaccines. And once we get beyond this pandemic, we do hope to expand that program. Next slide, please. So because we have the infrastructure in place and it was very, very easy, we, as soon as COVID vaccine became available for high school students, we went in to the high schools and vaccinated. And then once they were available for middle school age students, we went in and vaccinated. And we've just now finished our second round after school started this year in August. We went in pretty much when school started, and now in September, we've done our second dose clinics and we're finishing up with that. And what we found is that we're getting about 15% of the eligible students in the schools vaccinated in the program. Overall in our county, as nationally, about 35 to 38% of the students are vaccinated. So I feel that most of them, or at least half of them, are getting the vaccine at their providers. I think the biggest thing is that the people in this community trust this program. So when you segue to other vaccinations other than flu, they trust it. So in the lines of, if you build it, will they come? If you build it and they trust it, I do think they'll come. It's a matter of maintaining that trust and continuing the communication. I think that, as you heard, and we've done other surveys, people really want to hear about getting vaccines and what the pros and cons and safety is from their providers. We've surveyed UF students here also, and that's the same message. So the providers in the community are crucial to any of these programs. And I'll stop there and take any questions.
Thank you so very much, Kathleen. I'm going to go ahead and pause on the questions and move over to our final speaker on the panel, and then we're going to take questions all together. And again, folks, if you have questions for any of our panelists, please feel free to put them in the Q&A box, and we will get to them at the end of the final speaker. So last but certainly not least, I'm going to invite on Tim Benally, who is going to share his own personal story about how he is now connecting with young people in his community, and the importance of trying to get teens empowered to tell their stories, because that peer-to-peer education is extremely important. So Tim, without further ado, I'm going to invite you on to turn on your video and to present. Thank you.
Absolutely. Thank you, LJ. Can you hear me?
I can definitely hear you. Thank you, Tim.
All right, sweet. Thank you. So yeah, hey, my name is Timothy Benally. I am from the Navajo Nation, which is located in northeastern Arizona. I'm a recent graduate from Penn State University with a degree BS in Psych. And as mentioned, I founded the Indigenous Peoples Student Association. And with that, was able to work with the university to ensure that Penn State to recruit more Native American staff and students at the university. And so now I am a residence life coordinator at Penn State, and kind of taking a gap semester between undergrad and grad school, and really just have been blessed to be able to continue some of the initiatives that I started and do a little bit more research on the side. But as for my experience during the pandemic, or for the majority of the pandemic, I was on the Navajo Nation working as a public information officer for the Navajo Nation Office of the Speaker while finishing my degree online and being involved with a number of COVID-19 relief efforts. So in the Navajo tradition, it is an oral tradition, and so we love to tell stories. And my testimony here was easy to tell because there was a lot to tell and a lot of struggles that we myself and my people had gone through when it came to overcoming challenges related to COVID-19. So that unfortunately was the death of a lot of family members and friends, including my grandmother and one of my cousins, who were both tremendous leaders in our family and the community. I myself had COVID and almost died, unfortunately, with an esophageal infection in December, just because my immune system was so shot. And also my sister, she, with the Navajo Nation having shut down all our schools, she kind of risked everything to go and play basketball an hour and a half from our community. So she made that drive every day just to be able to go to college on a college scholarship, which an opportunity that she would have not otherwise had because all of the reservation schools were remote. And so with those three instances and a number of other things that I've seen, it was a very easy decision to get the COVID-19 vaccine, not to mention working with Navajo tribal leaders. A number of them were above the age of 60, and just having to work directly with them. I was able to get the vaccine in early February, which was a bit challenging and guilt-wise, just because you know that there are a ton of other elders that you're getting this vaccine before. And also, so you kind of have that survivor's guilt, but also frustration, as many of my Penn State peers were on class calls talking about how they were infecting themselves at parties on campus. So it was a huge internal struggle for a long time, but ultimately I felt I had to take responsibility, and that's really what led me to getting the vaccine, was to protect not only my coworkers but my family, especially volunteering and going to work in person every day. But in the process, I did do a video commercial with Johns Hopkins University. We were able to kind of get a youth campaign together, and I was one of their youth ambassadors. And I talked about why I received the COVID-19 vaccine, and also told others about like how they should get the vaccine as well. But although it was a good experience, I think it's important to note that I did get a lot of kickback for doing that commercial. People saying like, "Oh, he's a sellout," or "These people are just trying to continue to oppress minorities," which unfortunately is very understandable when working with communities like mine, who have a very low trust of the government. and of medicine in general. And so, much like my advocacy efforts to increase Native American student rights at Penn State, I think that with any campaign, you need to be willing to meet the needs of a whole person. So we're not just vaccinating and evacuating, where you need to evaluate your program and evaluate your own motivations, and ask yourself if you're willing to care for the needs of a whole person, or if your program is prepared to meet the needs of a whole person, especially with community being so important to like Native American tribes like the Navajo. You need to be willing to meet not only their physical needs with the vaccine, but also their mental, emotional, and physiological needs as well. So that said, these efforts, like I would say, need to be multifaceted. Like in my experience, sorry, I'm reading like you're just about out of time here, and threw me off there a little bit there. But yeah, with these multifaceted efforts, be sure that you're able to put in other efforts and suggestions to check on elders and encourage general checkups, and to meet the whole needs of individuals, because they are human. And yeah, just definitely leave room to take care of a whole person in these efforts, and don't just make it about just getting the vaccination and leaving. So that is my party advice, and I'm open to questions now. Thank you.
Oh, thank you very much, Timothy. I really appreciate you giving that presentation and reminding us about the people in the community that we're trying to serve as well. So I'm going to invite all the panelists, Kathleen and Judy, to turn on your videos, and then we're going to go ahead and start with our question and answer discussion session. We've got 20 minutes, so that should be plenty of time for us to get to some of the questions that are already that we already have. And you can see in the chat box the campaign that Timothy was involved in is on YouTube, and you can go take a look at that in the chat box, folks. Just take a look. We also posted in the chat box is some information from the Unity Consortium on a upcoming panel that they're hosting with the Clinton Foundation, and will be moderated by Dr. Chelsea Clinton. So so take a look at that as well. All right, so I'm going to go into the questions that are now coming up, and Timothy, I love the line, not vaccinating and then evacuating, because I think that's one of the things we've heard a lot with equity issues and minority populations, is that sometimes we go in there just to vaccinate and we don't take care of the entire preventive health needs of a community. So I'm going to use that actually to springboard to a question about trust. So we heard from all three of you, including Dr. Ryan here, about this importance of trust. And we all know from the surveys that have been done that pediatricians and healthcare providers are trusted sources of information for parents. So firstly, I want to ask, what strategies do you think you guys talk about, and Tim especially, for engaging healthcare providers in school vaccination and community outreach, so that you can use them as trusted sources? But then the second part of that is, how do we then inculcate trust from that community into the system itself? So the program that is delivering the vaccine. So like Dr. Ryan, your program, you said your program is trusted, right? And then, and Timothy, to your point, the health authorities that might be behind some of these initiatives, how do we expand that trust to them as well? So let's just start with that and talk first about strategies for engaging healthcare providers. Anyone just jump on in.
Hey, LJ, I'll get started on that. One of the things that is right at the forefront in terms of the issues with trust is what we're seeing on social media. And what we've been hearing from our parents and our teens is that they don't hear from their healthcare providers. They trust them, but they don't hear from them. And one of our moms last week said, you know what? I hear from my local pharmacist almost weekly. They are on social media and they're giving me data and they're giving me facts, and it's not opinions. And so what I would say is, as a healthcare provider community, you need to be heard frequently and on those social media platforms where your community is, whether that's Facebook, TikTok, Instagram, Twitter, whatever it is.
Thanks, Judy. Kathleen?
I'll jump in there. I agree that we need to be a face to the community as healthcare providers. Locally, what we do is we have town hall meetings that are put on by UF, and we have pediatricians that talk about vaccination in general. When we were beginning the control flu program, we did a lot of videos. We didn't do as much social media back when we first started, but we had, again, town hall meetings and other community events where we recruited the community pediatricians. And then we sent out a lot of other types of flyers and information about the program. But I think the message from the providers has to be clear and strong, and that we do need to engage in social media and promote those kind of things. When we have our town halls, and when we've done them also with UF around COVID, we have, hundreds and hundreds of community members and parents who join in.
Thank you, Kathleen. And Timothy, I'm going to ask you this, Tim, and this is the idea that, we heard about the importance of the provider, but what about now? How do you inculcate trust in, for example, your indigenous communities, in the program itself? And I'm so sorry you got pushback about your participation in that public service announcement, but that's the kind of trust, right? So how do you get them to trust the system and the program that, for example, Dr. Ryan here is delivering? If she came in with a program, how would you work to get your community to trust that program?
Right, yeah. So I was really fortunate enough to work with the government and to have friends in the healthcare system that explained to me very clearly what the vaccine was all about, and some of the common efforts that we had. So never underestimate the power of word of mouth and the positive aspects of social media. When youth like myself and like a few of my friends, like when we are educated thoroughly about the efforts. So in my case, I was heavily involved with the Navajo Hopi COVID-19 relief effort. So it was a program that helped with giving out PPE and care packages with lots of food, like a week's worth of food, to residents in extremely rural communities. Like I'm talking like dirt road, way off the grid. And so these were some of the most meaningful interactions that I had during the pandemic, was with elders and even friends who have young families, who would say, like, Tim, like, is this for real? Like what can I actually do? Like, what can I actually do to protect my family? So be knowledgeable about not only COVID-19 efforts, but even things going on in the local community. Like, for example, we had a stimulus check that the Navajo Nation sent out. Many people had questions about that and how to get their check. Just having that knowledge of the local community, as well as the knowledge of modern efforts. As a youth person, I was able to spread positive messaging just on an interpersonal level. And I think the more of that you can promote, especially with young leaders like this, and give them a place or a platform to step up, I think that's one of the best ways.
Thank you, Tim, for that. Do Kathleen and Judy, do you have any follow up on that? Because if not, I have another question that actually kind of ties into this a little bit, and I'm going to ask this because obviously this idea of trust ties into this idea of what kind of advice you all might have for your community or your school leaders that are now facing some fairly difficult political environments related to vaccines, and so how can community and school leaders push back effectively against the misinformation that might be coming within these kind of difficult political environments?
I
Who wants to go
again first?
Oh, let's have Kathleen, you go first, and then Judy, and we'll come back to you, Tim.
Okay. I think it's important to just have the schools be able to direct back to the science and to use the community medical providers as sources of information. We have people from UF that advise the schools on policies and procedures, and they can refer back to us in terms of the science. So we have to support each other because they'll get pushback, and if they don't have someone that can sort of have their back, so to speak, then they don't know how to proceed. But if they do, and they can say, we're getting this information from our community providers and our medical experts, then there's more meat in what they say.
I'm on mute. This is this idea of having the local experts in the community that are respected provide a backup for the community leaders who are pushing for school-located vaccinations. Judy, any follow-up on that?
Yeah, I totally agree with Kathleen. Support your trusted local, community partners. And in addition to, Kathleen's pointing out that the school administration needs support, I'll also say that the parents need support in a lot of these communities where there's a lot of mistrust. Once it becomes known that the parent has vaccinated their teen, they actually get a lot of backlash from their peers. So they need support to confidently say, I'm doing this for these great reasons. And so support the parents in their decisions, support the teens, as Timothy just said, he needs support. So let's remember to do that. And then I'll also just say, focus on the shared values, on keeping the adolescents and children healthy, that it's in everybody's best interest to do that now and in the long term. And stay laser focused on those kind of positive messages and don't repeat the negative messages because it only gives them airtime.
That's and the idea that a negative message repeated sometimes becomes the truth, right? Timothy, any comments on that? I like Judy's point about the fact that you as a community advocate want support as well.
Yeah, definitely. And really, it's hard to just chase arguments all the time because that's definitely what people want to do sometimes, especially in areas where it's kind of reinforced with, like, for example, like Navajo's history with the government, like that trust is always going to be damaged, at least for a long time here. And so, like with mandates, like they're not being mandates in a lot of places. I think the most important thing that you can do is take it seriously yourself and be genuine yourself in wearing your mask, even if you are vaccinated, and following all of these protocols and not relenting, even if you see other people doing that. That's kind of what I've chosen to do, and in being genuine, you kind of got to figure out how to love people, even if they never choose to get vaccinated, or even if that never becomes an option for them, and understand that you know, fortunately or unfortunately, that is their right. But still, don't let it deter you from taking it seriously yourself, and ensuring that you're taking every single precaution, just personally, and continuing to express your values and why you are doing what you're doing.
Thank you, Tim. I think you tell a really compelling story. I'm going to move on to another question because it is related to what we're talking about here. Clearly, you're talking about support, right? And I think one of the things that all three of you have mentioned already as part of your presentation is this idea that it takes to borrow terminology, it takes a village. And all of you have used relationships. And so I want to ask all of you to talk about the relationships and partnerships that you want to advise people to inculcate to support efforts to reach out to these communities. Timothy, you want to start first this time? What kind of partnerships will help you with your efforts to do your outreach?
That's a good question. I wasn't ready for that. But I think just really looking out for people who typically fall by the wayside. Looking out for, like, for me, some of the most meaningful partnerships that I've made have been in the middle of the Navajo reservation. Like I said, miles from the main road. My girlfriend actually is from a border town, as we call it. And so in that border town, that's where the majority of resources are for our people. Like, that's where the nearest Walmart is, and the nearest fully equipped hospitals are. And it's kind of where everybody goes on the weekends, if you know what I mean. But that border town is probably about 2 hours from where I lived, which was in the heart of the reservation, where resources are very scarce, and there's not fully equipped hospitals. There's rather clinics, and where there's small grocery stores that tend to be overpriced. And so in our efforts, she would get like a lot of resources from there, where honestly a lot of people with resources would donate, but they would go to people in the immediate area. And so working with her, we were able to get some of my friends and bring those care packages all the way to the middle of the reservation, the places where people had the greatest need, but kind of fell by the wayside. And so we were able to create those partnerships, and luckily those mutual aids were able to continue to call those the people in the middle of the reservation, and see if they had any people that they knew that needed referrals or needed resources. And yeah, just like that word of mouth and being able to pass it on was probably the most meaningful relationships that I was able to cultivate.
Timothy, thanks for that. And you know, the reason I'm smiling also, it reminds me about this idea of access, right? So much of success is access to vaccines. And I know we're talking about access to schools, but you've pointed out a very important point with a lot of rural communities is, you know, where is the best access points for vaccination? And I think forming partnerships to try to get access to vaccines for people that are in the middle of nowhere is extremely important. So thank you for that. Judy and Kathleen, partnerships that you all form for your programs. Go ahead, Judy, you go first, because then Kathleen can go after that.
Okay, thanks, LJ. And Timothy, thanks also for sharing that particular point of view. You know, at the local level, there is a infrastructure that currently exists, and LJ is really familiar with this. It's your immunization coalition. So I would say work to strengthen that coalition, because I have seen, for example, in Sioux Falls, it's just a great infrastructure to get all of the folks in the community involved around immunization. And that includes folks like public health, like the schools, pharmacies, you know, integrated delivery networks. and those community organizations that have fairs and have outreach in the community. So strengthen your immunization coalition, join them, and become a active participant. I'll also just mention, I think Jane put in the chat box or the Q&A, Unity has an initiative called Community, and there's a link to it where we support those immunization coalitions at the local level. So, that's the infrastructure. And then we have lots of resources to provide kind of in a turnkey manner. So it's supporting both from the national level as well as the local level. And then just a reminder, as Timothy just said, get everybody involved who's relevant in your community, those underserved areas or communities with low vaccination rates, and make sure that you have a person who can speak to those communities in that coalition.
Thank you, Judy. Kathleen, partnerships that you formed.
So I think that locally we have used a lot of different community organizations, but one of the ones that is really important, especially in rural areas, we're in the Southeast, so our religious organizations, I don't think we can forget about them as part of the village. If you can engage those as well, they can really help support programs. They can, in communities of color, if they're supportive of things, they're going to be a trusted source of information. So I think reaching out to those types of leaders is really important, along with everything else that Judy has mentioned. But it does increase access, especially if you take vaccination programs even outside of the schools and into those areas. You can increase access to vaccination in general.
Thank you so much, Kathleen. And I, we're out of time, and there's so many more questions that we could talk about, like, about the idea that safety concerns remains one of these most challenging, thorny questions that you pointed out, Jody, in your survey, and how do we address that in social media? But I think, unfortunately, we're out of time. So what I'm going to do now is thank our panelists, Timothy Benally, Judy Klein, and Kathleen Ryan for coming on and sharing their experience. I think this is what they shared. It's not just their wisdom, but also their experience of how to get into these communities on the ground, conduct surveys, and get them vaccinated. So indeed, I think the answer is if you build it, you can get them to come. But in order to do that, you need to build trust. You need to build communications channels that are transparent, and you need to build relationships, very unique ones, clearly, that suit the community that you're trying to get into. So thank you very much to our panelists. And I'm going to now turn this back to our hosts. And again, thanks, everybody.
Hey, LJ, thanks very much. My thanks to the panelists as well. What a great discussion, not only
Thank you, Dr. McClellan.
Thank you. But what a great discussion, not only in this third panel, but throughout the day. I really appreciate all of our panelists highlighting their important work, not sugarcoating it. Clearly, this is hard. There are challenges around safety concerns, many other types of communications issues, many logistical challenges, financing and sustainability challenges. But it's great to see the important progress, the important achievements that have been made through partnerships and through ingenuity and adapting to local circumstances to get to effective school-based vaccine programs. I'd like to extend that by thanking all of you who joined today. And I want to emphasize that while we think this was, we hope this was a very helpful event for all of you, I certainly learned a lot in each of these major issues and key areas related to effective school vaccination programs. This is not the last word. So we heard a lot on, as LJ just summarized on this last panel about overcoming communications challenges. They are very real, they are important. The misinformation issues are also challenging, but there are effective strategies to address them. We heard a lot in the first panel that I moderated moderated about effective ways for setting up these programs and even looking ahead to how to sustain them effectively, and lots of ideas in the second panel on the variety of approaches to vaccination programs, how to build the partnerships, and how to overcome challenges in getting there and succeeding. We've taken a lot of notes. I hope you all have too, around those challenges and around how to overcome them. We are going to be doing further events and activities along the lines of today's events. We're going to make this recording available along with links, as you all have identified, to a lot of resources to support effective vaccination programs. And going forward, we want to be helpful as you continue these efforts and hopefully to sustain them. As we were just hearing about, as Tim just said, this isn't, you can't just vaccinate and evacuate. This is an opportunity to build longer term collaborations to support public health through schools, to build relationships and trust and the capacity to address the very important challenges in public health and health equity that we're facing today. So moving forward, we want to continue to be of assistance. We'll continue to try to pull together these experiences and show you some practical tools that can be used and experiences that can be built on to expand the use of school-located vaccination in your own communities. To that end, as soon as we're done here, we hope that you'll fill out a brief survey appearing after the conclusion of this event. We're going to email it out to you as well. We do want your feedback on the event itself, but this is about something beyond that as well. What we're asking you in this survey is, what additional questions do you have, or additional events like this or tools like the ones that have been linked here today would be helpful to you going forward. So learned a lot about those today, but we think there are opportunities to build on the approach we've taken too. So as we've talked about, there are many models that could potentially be replicated or maybe more accurately adapted to your local circumstances, but also continuing challenge that you all are facing, including reimbursement issues, coordination issues, regulatory issues. We've taken notes about a lot of those already, but again, we want to hear from you to make sure that this collaboration is as effective as possible going forward in the days and weeks ahead. So we're looking forward to continuing to engage with you as key partners in this collaborative work. And I'd like to give a special thanks to our panelists for their time and effort, to all of you who co-developed the content here through your questions, suggestions, and sharing of resources and perspectives. And then also a special thanks to the people who put this together, our team here at the Duke-Margolis Center for Health Policy, our colleagues and close collaborators at the Association of Immunization Managers, in particular, Mackenzie Melton, Caitlin Wells, and Emily Less, and our partners throughout this pandemic at really from the earliest days at the Rockefeller Foundation, including Leah Perkinson. In terms of our particular staff support here for this event, special thanks to Katie Huber, John Bollinger, Katie Green, Luke DeRocher, Ethan Chupp, and Neil Rowan. Lots of time and effort to get us to this point. So just to close, please do fill out that survey after this event is over. It'll be emailed to you as well. And please feel free to reach out anytime with comments, questions, and resources. The work that you're doing is what's going to make the difference for protecting our children and getting us beyond this pandemic. Thank you all very much, and I hope you have a good rest of the day.